हेलो। बोल रहा हूँ 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 बस।
Good afternoon, all. I'm Dr. Sharmili Sinha, an intensivist from Bhubaneswar, India, and I have the pleasure today of inviting you all to this studio session with my co-interviewer, an eminent intensivist, Dr. Ronajit Chatterjee from New Delhi, India. And also, I have the honor of having very eminent panelists from India and across the world with me to discuss about a very interesting topic about future of intensive care. I have with me Dr. Jen Louis Vincent. He is known as father of modern intensive care, and he needs no introduction from Brussels, Belgium. And we have Dr. Deepak Govil from New Delhi, Dr. Rajesh Pandey from New Delhi, and Dr. Asit Hegde from Mumbai, India. So with that, we start our sessions today. Now, critical care, as we see today, it has evolved over the last 7 to 8 decades from a nascent stage to the current stage. And with the constant technological advancements and renewed research, the expected standard of delivery in this fraternity has really gone up. And but with the constant change in the social, economic, and political status across the world with the war going on now, it's become a challenge. If we'll be able to have a sustainable development in critical care, and will you be able to implement this in the healthcare delivery services across the world? So let's hear it from the eminent panelists today with my co-interviewer, Dr. Ronajit Chatterjee. Over to you.
Well, good afternoon to you all. So let me start directly with Dr. John Louis Vincent. Sir, what do you think? What will be the situation of intensive care just after 30 years? How do you visualize that, intensive care 30 years from now?
I think we can summarize the atmosphere in 20, 30 years from now by one single word: personalized. I think we will not try to use protocols that could be applicable to every single ICU patient. We will rather identify the profile of every single patient and treat the patient accordingly. Like in the past, but in the recent decades, people have tried to do big trials to have very easy answers to very complex questions. That doesn't work. These trials have been negative one after the other. Hopefully, artificial intelligence is coming, and artificial intelligence will really help us to clearly identify the personality of each patient, the particular setting, the particular type of response. And this will enable us to give the most appropriate treatment. So this is very exciting. It won't take 30 years. the technical advances go so fast that already in a few years' time, we will see a big change there. And the patients will actually be treated by more technological support, I mean IT technology, that will automatically collect many variables at the bedside, integrate them, and help in choosing the best treatment. So the doctors will have more time to talk to the family, actually, and we will need less nurses, less people at the bedside, but for a better quality of care. So this is very exciting.
So that's very interesting to know as well, Dr. Vincent. So my next question will be to Dr. Rajesh Pandey. Do you think it is going to be more robotic in the field of intensive care? Will more be machines and computers will take over human tasks in the coming years in critical care?
I think this has been partially answered by John Louis, that artificial intelligence will come, but automation, robots, I don't know whether they will be to help the patients, fine, but to make decisions regarding intensive care and critical illness, possibly no. So from protocolized based medicine, we'll be moving to personalized medicine, where the vast majority of data, if we apply the AI algorithms, we can fine tune as to the response, as to the genotype, phenotype, and we can see which treatment is best for the patient. So I think that is where the future of medicine lie. Of course, automation would come. All the equipment, as the computer advances, they will increase in the advancement and the intensity. Possibly they will be looking more at the patient comfort and the staff comfort. As of now, the algorithms that we can give for mass application are very, very few. And that too in the near future will change, because we are moving away from protocolized medicine.
Well,
Thank you.
that leads to the next question to Dr. Govil. If at all we are going to be so much of using machines and technologies, how do you think that the structure of the ICU will be after next 30 years? Any changing in the nursing skilling patterns? Any other changes that you are visualizing?
I agree with the previous speakers that the AI and this automation will change the scenario of ICU, but the nurses are the backbone of the ICU. I don't feel that there will be any change in the nursing care. Rather, the nursing care should become better and better every day, so that the doctors can devote precious time to treating more patients, and more things can be managed by the nurses. And with AI and this automation, again it will help in solving many problems and raising the flags where sometime we miss in the critically ill patients.
That sounds good. So we are all kind of conquer that there are going to be more technological advancements, more involvement of artificial intelligence and machines. They're going to make our jobs easier. So in that context, a question arises: what about the future of jobs for doctors and the medical and paramedical staffs in the intensive care unit? As you have said, nurses will continue to have their crucial role. But what about paramedics, physicists, pharmacologists, etc.? My question to Dr. Asit Hegde.
I don't think you will completely take away from the jobs of human beings. I mean, you have artificial intelligence, but they're just to advise. I don't think they can replace human beings, but jobs might, it might be more integrated. I mean, you will have, like I said, you'll have a clinical, right now I think intensive care is, one person is doing several things, but maybe in a way that will be broken up. There will be one deciding about, infectious disease, one for pharmacology, like a clinical pharmacist. Each one will, it'll probably be a group of people looking after one patient, and it will not be just one person. So I don't think, and because of, it's going to be probably easier to look after, like, because telemedicine, it might also be possible for that one team looks after many more intensive care units. So though I don't think the jobs are at danger, but one individual or a group of people will be looking after many more beds rather than one person looking after one bed. That's what I would think, that the responsibility will be divided across a larger number of patients. So overall, I don't think the number of, doctors would reduce, but they would probably focus on one aspect over many more patients rather than focusing on 10 aspects on one patient, which I think is in the patient's interest, that you look after what you are best at. And you obviously use AI and all these other gadgets to help you, but I don't think it will replace you.
So you believe that jobs would be there, but it will be kind of restructured, the job responsibility and job description will change. So that sounds good.
So that's quite reassuring, actually, from your side, that we are quite concerned about whether the number of jobs will decrease by dehumanization of the ICU. So if I go to the artificial intelligence again, Dr. Vincent, I mean, can I just ask you, actually, can you give some examples of this? Because you are telling that you want to personalize the treatment. You use artificial intelligence. Is personalization and individualization of the treatment, including the clinical acumen of the physicians, will still be relevant that time, or will only depend on the artificial intelligence tools? So how do you do that, basically? Give some examples.
Well, first of all, we should not be afraid of these developments and think that machine will replace human beings. Not at all. The machines will help everyone. The patient first. Patient is the center of our preoccupations, and the personnel working in the intensive care unit. So I don't think that our treatment will be dehumanized, not at all. It will be more human, because the patient will benefit from more information. We will have more time to spend with them. The families will have more discussions with us, doctors, nurses, etc. So our job will change somewhat, but we will still be there, and we will still supervise what the automated systems will do. Just to give an example, right now, we of course try to avoid any pain in our patients. But how do we evaluate pain? You know, do you believe in these scales in those patients who are very ill? They don't have their glasses. They can hardly understand what you are asking for. An artificial intelligence system will look at how you behave. The patient who sleeps comfortably will not need much pain medication. But if the patient starts grimacing, sweating, developing a bit of tachycardia, a bit of hypertension, moving in the bed, all these signs taken alone may not tell you so much, but if you integrate it with an AI system, you can very well identify the patient who will need more pain medications. It's already done in the operating room. We start to do it in the operating room. So we will do it in the ICU as well. So nurses will have less to do at the bedside, and they will have more time to do other things. And indeed, interact with the patient, hold the patient hand, make sure that we understand what the patient needs, make sure that the patient understands what's going on. So it will be more humane. Don't worry.
So that's again quite reassuring that it will be more human. But the way our population is increasing, Dr. Govil, in India, and especially at the remotest part of India, it's very difficult to give specialized services there. So my question, I'll divert it now towards telemedicine. As we already know that the concept has already started in India, so what do you think? Are we going to progress towards this telemedicine side and behaving in that way, treating patients in the periphery, most of the remotest of the areas with the help of telemedicine? What is your idea?
Yeah, definitely telemedicine is going to play a big role in the future of critical care. And mind you, telemedicine can be used in a two-way. One is where we are just monitoring the patient, and with the help of telemedicine we can identify that this patient is at the risk. So the BP is going down, his saturation is low, heart rate is varying, that if there is nobody to look after that time, the central hub can raise an alarm and appropriate action can be taken. That is one part. Another part is a teleconsultation, where a consultant is not available at that remote area and somebody sitting in the big hospital or in a hub can direct to those people, those who are here, that now this patient requires this type of services, this type of medication, this type of procedure, and if that procedure is not available there, then he can or she can dictate them that why don't you shift this patient to another place. So that thing will help in the telemedicine. It will improve the patient care. It will go away with decrease the errors and the mishaps, near misses, and it will increase the reliability of medical services to the smaller places. People will not rush to bigger places immediately. They will have confidence that the same consultant is remotely looking after me in this remote area as well. And if need be, we will be airlifted or chopper lifted to the bigger center. So it's going to stay there.
All right, just to move on to the next question before Sharmili asks, I was thinking, don't you think that people will be more comfortable at their homes after 30 years? They will try to live at home, to have a home care in the form of ICU. Do you think so? Any one of you can take this question.
Yeah.
Well, home care is now we have moved to a different dimension, because home care would not be applicable to patients who are very critical, who needs to be in the intensive care unit, who needs to be nursed, maybe patients who are recovering, maybe patients who are chronic, who are tracheostomized, and there we can have, it's still being done. So I think the hub and spoke model will expand regarding the remote, monitoring, and with fewer manpower who can be placed, remotely, using the larger group of, doctors at the hub. We can monitor them, we can advise them, and maybe the same is it's also being applied in the at the homes when we are discharging these chronically ill patients, where we can't keep them indefinitely in the hospital. So that also is being done. It's not that it is the future, it is already being done all across the globe. So we can monitor these patients better, and we can the person who is at the bedside at home can seek advice from the central center and act accordingly. If the situation deteriorates, the patient can be rushed to a hospital, or depending on the wish of the family, whatever care is required at home, that can be delivered. So I think it's very much there.
Right, sir. So, as we have come to this current stage from over the last 7 to 8 decades, so just when you compare the ICUs of 1990s of today's, like 2023, we are already at here, there have been a tremendous change in the way we empower, or you put personal strength, engage personal strength in our ICUs, kind of machines we employ, and also the new challenges have emerged in the form of rising constant threat of rising antimicrobial resistance and new pattern of diseases. We all have witnessed this devastating COVID pandemic in the last 2.5 years, and also we have now more emergence of subspecialty ICUs in the intensive care units. So in that context, Dr. Hegde, I would like to hear from you how you think like critical care fraternity is going to be, you know, equipped or to plan for facing any such kind of disaster in the future, if at all any. And number two is what do you think should be our strategy for antimicrobial resistance? To Dr. Asit Hegde.
No, one, of course, I mean, we were unprepared for the epidemic, so now that we have some kind of idea, we need to obviously prepare. We need to designate areas in the hospital which can be quickly converted to, you know, in case we need them, which can be quickly converted to intensive care units. So if the need arises, they obviously need to be negative pressure and all that. But they can, when it is not, when there is no epidemic, obviously they also need to be used as a regular bed. But we need to have the ability to quickly convert certain areas of the ICU to certain areas of the hospital to an ICU at short notice. That is obviously the first thing. So backup equipment might be needed in a case. I mean, of course, that might give you some kind of warning, but that is what I think you need to have the capability of designing hospitals such that they can be multi-purpose, you know, your in regular wards in regular situations, but quickly convertible to ICUs in the future. That's about, you know, design. Of course, other things, equipment, all the other things we will. But you talked about antimicrobial resistance. Most important really thing is going to be molecular diagnostics. I think we are going to require much faster diagnostics, and I think we're already there. I mean, now we're having more and more molecular diagnostics. I think sooner or later we are going to get a situation where within a few hours of collecting your blood, you're going to get the organism, you're going to get the mechanisms of resistance, you're going to be able to give the right antimicrobial in time. And as everybody has talked about, if you have individualized medicine, maybe depending on the patient profile, maybe depending on his height, weight, other things, the right dose for that person, you may be able to get even therapeutic drug monitoring pretty quickly. So maybe each dose would be individualized. You won't have one dose fitting all, just weight-based. Depending on the whole metabolic profile of the patient, they may be, AI will probably help to decide what is the right dose, what is the dosing interval to be given. So all that will probably happen. So I think essentially quicker diagnostics, and AI will probably helping us in selecting and dosing antimicrobials will be the future, in helping us deal with this resistant pathogens.
So in the past, like way you and me were training over the past few years, there were, when we started training, it was all multi-specialty ICUs. The variety kind of patients used to be treated in same unit. But now with the involvement of time, you know, more understanding of the physiology and the care and more involvement of the specialized doctors, now we've started having more subspecialty ICUs, like we have neurocritical care unit. We are talking also about having more and more obstetric critical care units, similarly gastrointestinal units. Somebody had put forth the suggestions for nephrocritical care units. So what do you see the future is? Like, are you going to, once you start dividing like this, is it going to be good or bad, or it's going to be more challenging? Because personal strength will be an issue in this matter, of course. Well, how do you see it, Dr. Hegde?
Me again? Okay.
Yeah.
No, I'm personally against, I think ultimately intensive care is managing physiology. And physiology to me is the same no matter what your primary ailment is. So I personally am against specialty ICUs, because though you become strong in one area, you become much weaker in the other aspects of intensive care. And almost never is intensive care, somebody with a stroke can develop a pneumonia, he may develop a UTI, and usually those people who are doing only with strokes are not competent enough to deal with them. So I really would expect, I think I would probably, I mean, though I know it's heading in that direction, I'm not very happy in that direction. I really think it should be a general ICU, and you can take multiple opinions, but I still think the ICU should be general, because I don't think intensive care ultimately is all about managing physiology, and you need to know about physiology all over the body, not just of one organ specific physiology. So that's my personal opinion.
It's a very
I would like
point.
to respond to this.
Yes, please.
You see, when we started developing subspecialty ICUs, it was for logistic reasons that, similar kind of patients like cardiac surgery, pediatric, they should be grouped separately so that the nurses can look after them better. But over a period of time, this organ-based ICU approach is absolutely bad for our trainees, we are producing intensivists who can only look after one particular aspect of human body, and when it comes to anything else, they are afraid, they want that patient to be shifted to a general intensive care unit. So I think we need to take a U-turn and come back where it is a holistic, all organ inclusive critical care. So I think that is the way it should go in future. Whether it happens or not, I don't know, but that is the way I look at it. I completely agree with Dr. Hegde.
This is a very pertinent point.
I
Please.
disagree with both of the speakers. I'm working in a specialty hospital where I'm looking after two different sort of specialized unit. One is the liver transplant, and we are doing close to huge number of transplant, 20 transplant a month. As far as Dr. Pandey is saying about the training of the trainees, the fault lies with us. We should have a judicious rotation to all the ICUs so that he or she can be trained everywhere. But believe me, if a person, like, just imagine a common man, they go to a surgeon who is doing maximum surgery in that area. Same way, if I am sick, I would like to go to that ICU where similar type of disease is being treated in n number of patients, so that not only the staff from right from the GDA, pharmacist, sister, doctor, everybody is tuned to deal in such type of patients, rather than a mixed ICU patient when everybody is just know little bit about that disease.
Thank you, Dr. Govil. In that context brings to me a question to Dr. Vincent. Actually, I'm coming to you. Your quick opinion
Thank you.
about
I have still a lot to say about the previous questions.
yeah, about
but there are
the
so many questions.
subspecialty ICUs and
But
closed versus
yeah.
open ICUs.
No.
Thank you.
We are going towards personalized medicine. The patient is a person. You cannot say I will take care of the brain and not the rest of the body, or just the liver transplant and not the rest. The patients all develop the same kind of complications. The patient with a neurosurgical problem may very well develop a lung infection, a ventilator-associated pneumonia. The patient with liver transplant that you speak about may very well develop liver encephalopathy, renal failure, sepsis. So all the patients can develop the same kind of complications. And so we don't want specialty ICUs where doctors who are a specialist in one organ want to take care of all the problems that these patients may have. We need a system in which the specialists are involved, and that's your point, that if you have many patients with liver transplant, it's very good to have an excellent team of liver transplant doctors and other members of the staff who will come and discuss with us. And that's what we do in our center. We have many transplant liver disease patients, and we do it with hepatologists. But the hepatologists are very happy to have their patients in our department. And so we should not go back as in the past and have a neuro ICU, a respiratory ICU, a real ICU. No, please, no, that's not the right way to go. We need to consider patients as a whole. That's what I call personalized medicine. Likewise, you know, in the US, they still have a separation between the medical ICU and the surgical ICU. What is the difference? A surgical patient is a medical patient with a scar. That's the only difference. The surgical patient will develop the same problem with intravenous catheter infections. They will need intravenous fluid. We'll have the question, what is the best type of fluid? They will have nutritional problems, the same, etc., etc. Stop separating medical and surgical patients. That was history. That was in the
And
past.
quickly to Dr. Vincent, who do you think should be the in charge of ICU, the intensivist or a primary physician / a surgeon?
No, there is no discussion about it any longer. We should no longer have open ICUs. ICUs are managed by people having a sufficient, adequate training, whether the primary specialty is in internal medicine, anesthesia, surgery. That doesn't matter. This person who is an intensivist should have a sufficient knowledge and training. And so this is a specialty on its own, of course. And hopefully the anesthesiologist will no longer say, we are the intensivist. No. Anesthesiologists work primarily in the operating room or in the pain clinic, or they do their job. but they cannot take care of very complex patients in the ICU. We need people who are intensivists, but that's increasingly recognized everywhere in the world.
So that's very encouraging, and let us hope that what you are seeing, what you are visualizing today, that actualized after 30 years. But the way we are progressing, I will find it quite difficult to attain that. The way we are subspecializing ourselves. In India, we tell it super specialization otherwise. Well, now if I just move on to a different side of the story, you must be agreeing with me that the first time antibiotic was discovered, it was in 1940s. And now after so many things, we are coming out to a post-antibiotic era, more or less, 1923. Now, 20 years after, 1953, when the situation will be more challenging, in that situation, should we change our goals in intensive care? Now our goal is only mortality, 28-day mortality, 90-day mortality in most of our studies. Are we going to change our goals? Are we going to change our study patterns that we are doing, as you initially told, that you are not a big believer of RCTs in intensive care? Should we change our goals? I'll start with Dr. Pandey and then come back to you. Sir, do you want to change the goals, the standards that we set up with the ICU?
Well, I would say, different issues are different. They are not alike, so they cannot have the same goal. Mortality is, multidimensional in critically ill patients, so this will depend on a lot of factors. If the issue relates to the comfort of the patient or a particular aspect of the patient, then you cannot take mortality as an indicator. But when the mortality in the existing critical illness for that particular disease is very high, then obviously any drug or intervention that you are looking at for reducing the mortality, the 28-day mortality or 60-day mortality has to be the outcome. We have seen in the past that when people try to reduce or change the goalpost by shifting the mortality, UFAS trial is an example. I mean, all the previous trials done with toremixin showed that it improves the hemodynamics, the cardiovascular SOFA improves, but that was a very, very limited outcome. And when they finally did the study, the randomized control trial, they couldn't prove a mortality benefit. So I think somewhere we need to choose our targets very clearly. What is the area in critical illness that we want to study? And accordingly, I feel the outcome goals have to be differential.
Well, Dr. Vincent, do you think so that we'll only stick to the mortality part? Because if you see the mortality percentage in the ICU, it's quite high. Shouldn't we set certain goals where a patient, also if the patient dies in a much, in fact, dignified way? That has to be seen. Is it the only mortality that we choose for the success of the ICU? Do you think so?
Yeah, yes, of course. There are two issues with the progress in prospective randomized control trials. One is the heterogeneity of the patient population. The other one is the mortality as an endpoint. So if we take the mortality as an endpoint, yes, indeed, mortality is influenced by a number of factors. Any investigator will say that when he or she wants to enroll a patient in the trial, the colleagues say, oh, you may enroll the patient, but this patient will obviously die. This patient will never leave the hospital alive. Or you may enroll the patient, but but the patient is already getting better. Of course this patient will survive. So it's already done. It's already there. And your intervention is very unlikely to change the fact that the first person is 85 years old with a little bit of dementia and a neurological impairment and will not make it alive. And the other person was a well-fit individual who got a severe infection, but obviously is now getting better. So we must realize that mortality is indeed influenced by many factors, including patients' preferences. In Europe, it's very clear. Some patients' families will say, oh, my father would not want all this. Or on the contrary, oh, my father will have a miserable life, but he has always says, as long as I live, I must live. So that influences the outcome, obviously. And in our center, very often, we put the life to an end when we feel that the quality of life will be too poor. So that patient will not survive the ICU stay. We will increase the doses of sedative agents and stop respiratory support in the intensive care unit because we feel that's the right way to go, because we will all die one day or another and we don't need to have machines around us. So all of this can influence the crude mortality rate that you are hoping to change significantly with your intervention in a heterogeneous patient population. Doesn't work. We have to realize that it doesn't work.
Can
Thank
I
you.
add one thing?
Yes.
The more personalized approach we are taking, more heterogeneity in RCT will be there. Because now in RCT we
No.
take a cluster, but the moment we become more personalized, the more heterogeneous bias will be there, sir.
No, I hope you will be with us in Brussels next month. At
Yeah.
ISCCM, we'll have a roundtable conference on precisely how to better identify the patient who may benefit from an intervention. We just heard about polymyxin-based extracorporeal support. Why don't we look at endotoxin levels? I know it has been done, but that's the right approach. If you want to have an anti-hypertensive medication, you measure blood pressure. If you want to influence cholesterol level, etc. What have we done in our sepsis trial? Oh, the patient has some fever, the patient looks bad. Let's put the patient in our trial. No, no, that's too heterogeneous. So AI will actually help us to identify the right group or subgroup of patients who may benefit from this intervention. Like in oncology, you are not looking for anti-cancer therapy, you are looking at various types of cancers. And that's what we should do in the ICU as well. So I think we are going in that direction with the proper biomarkers, not necessarily very sophisticated, but the right measurement for the right intervention. I think we are going in that direction.
Well said, Dr. Vincent. So that brings to a point that we need to probably, it's time to reorient our education, our training and understanding of the pathophysiology of the diseases and the person's own genetics and phenotypes that we have been talking about. So let me ask Dr. Asit Hegde, how do you think our teaching and training in critical care fraternity should be now oriented and targeted at, and what are the challenges and how do you address it? Dr. Asit.
Before we come to critical care, I think we should talk about basic education, medical education in India. I mean, you can get through your MBBS, become a doctor without knowing about BLS and ACLS. You don't know anything about, little about sepsis. You don't even may not be able to identify sepsis, may not be able to define sepsis. That's about MBBS. I passed my MD medicine not knowing a thing about sepsis, not knowing a thing about CPR, not knowing a thing about antibiotics, but I knew everything about mitral stenosis, which I never seen in my life after that. So I think the whole education system in India has to change first. And then coming to the three specialties generally enter intensive care, internal medicine, respiratory medicine and anesthesia. Their curriculum has to have a big section devoted to critical care, which is non-existing. Like I said, you can pass your MBBS at MD knowing nothing of, therefore we need to change our focus. That is at that level. After you join intensive care, of course, the curriculum needs to change. You need to know microbiology needs to get the importance it deserves. Soft skills in critical care, which are not being taught that much nowadays, need to know. End-of-life decisions need to be taught. These are soft skills. But I think before we come to critical care, the primary education needs to be overwhelmed first. I think then, of course, we need to
Yeah,
change.
just continuing that, I would say the feeding, specialities for critical care as a super specialty has been in traditionally anesthesiology, internal medicine, and pulmonary medicines. In that context, I would like to highlight the recent changes in the Indian, healthcare system, and especially regarding the entrance exams for the super specialty branches. That anesthesiology has been excluded from the curriculum towards entrance for the NEET exams, which is a super specialty entrance exam for critical care. So I think that is a very important area that has to be looked to. And just quickly from Dr. Vincent, what do you think about the global, about Dr. Asit mentioned about the undergraduate curriculum featuring at least some basic aspects of critical care? Do you agree with that?
Yeah, I've been the first teacher in intensive care and emergency medicine in our university. And so I started something like 25 years ago. And it has been very appreciated by the students. But importantly, as it was said around the table, we should revisit the way we teach as we start with an illness, and we say, okay, let's talk about hepatitis, bam, 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 bam. No, 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 no. We should start with a patient. And that's how I asked my questions at the end of the year at the examination. I said, okay, you have a patient coming in with hypoxemia and bilateral chest infiltrate, etc. And the student should speak about the management of ARDS. But the question is not, what is the management of ARDS? No, people must identify it. So we should always start with a problem. And once, as you go along, you can add some elements. The patient needs to be fed. How will you feed the patient? Now the patient becomes hypotensive. How do you assess it? Don't tell me you just put the patient on noradrenaline. No, 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 no. Think at what the cause could be. Think at, is it a high blood flow, shock? Is it shock? Have we seen the lactate level, etc., to have a very pragmatic approach to illnesses.
Thank you. That's very enchanting, Dr. Vincent. The last question on a lighter note to everyone. In Sanskrit, we say, Vasudevaya Kutumbakam. The whole world is our family. So do you think that intensivists will be more mobile in the next 30 years? Maybe I find Dr. Govil treating patients.
Yeah, they are still mobile. So in India, there are many intensivists who are through telemedicine treating the patient in US, sitting right here in India.
So you are already mobile?
Already mobile.
So you are already mobile.
And there is a time zone gap between the UK and the Australia, and many people are doing the night shifts in sitting at the home in the UK.
So maybe after 30 years we find this more frequently to be done?
Yeah.
Well, thank you,
So
ladies.
work from home is coming in medicine as well.
And in that context, I'd also like to feature that global collaboration. When we say whole world is a family, that's what we see. We are all sitting together, Dr. Vincent from Belgium and many other colleagues from across the world here at Criticare 2023 in Indore. It's really a pleasure and delight to see such things happening. But I sincerely believe more and more collaboration should happen between the high and low middle income countries, and we have to facilitate each other, not only in terms of research and also how to personalize or customize the treatment and delivery of services in those respective zones.
So, well, it was an excellent discussion, and we hope whatever we fantasized or visualized today, time will only tell, and we hope that all of us should be there to visualize it after 30 years. But I can tell you that we intensivist community will keep no stone unturned for ultimate patient satisfaction and care. Thank you so much. Thank you.
Thank you.
Thank you.
Thank you so
Thank
much.
you all.
Thank you.
Start. Start.
Good afternoon, everybody. Today we have with us Dr. Ram Rajgopalan, who is the Professor and Head of Clinical Services, Department of Critical Care Medicine in Sri Ramchandra Institute of Higher Education and Research, Porur, Chennai. Also we have with us Professor Kulkarni, who is the Professor and Head, Division of Critical Care Medicine, Tata Memorial Hospital, Mumbai. Among the interviewees, we have with us Professor Pradeep Bhattacharya. He is the Professor and HOD in charge of the Trauma Center and Dean Research of Rajendra Institute of Medical Sciences, RIMS, Ranchi. And myself, Dr. Sulagna Bhattacharya. I am an Assistant Professor in the Department of Anesthesiology, AIIMS, New Delhi. So we start with the interview today.
So today we'll be discussing about this grade recommendations. Grade is something which has come after the evolution of evidence-based medicine, which we all know that it has started in the year 1990, and Gordon Gott is considered as the father of evidence-based medicine. Subsequently, he developed this grading system, and now this is one of the best system to develop recommendation for different kind of practices. Grade recommendations has been adopted not only by WHO, various scientific bodies, it has been adopted by British medical journal systems also, and now it has been extended as far as critical care is concerned to surviving sepsis guideline also. We see that it has been a very good system, and people are gradually liking this system for its robustness. So that is what we are going to discuss here today, how this grade system works, and how it is useful, how far it is useful as far as different kind of recommendations are concerned, and we'll try to convey the message that for developing good recommendations, we need this grade system for our future. So to start with, my first question goes to Dr. Kulkarni. Sir, what is grade?
So grade is a way of development, assessment and evaluation of recommendations depending on the evidence that is available. So the guideline makers actually use the levels of evidence and assess that, how to assess that evidence and make a recommendation depending on the type of evidence that is available. So it might be strong, it might be weak. When you say recommendations, generally they will be worded as either strong or weak, and then you will have a level of evidence that is given after that. So it makes it easier for the clinician, and if the patient is reading it, it is also easier for the patients how they take it up.
Could I add something to that?
Yes,
just
yes,
purely,
Doctor.
I come not as
Yes, Dr. Ram,
yeah,
please.
I'm coming not as an expert, but as a user of guidelines. And what has always been frustrating about guidelines is the fact that while recommendations can be either strongly or not so strongly made, okay, there are sometimes a big problem, because these recommendations are based on the opinions of the individuals who looked at these guidelines and need not necessarily correlate with the strength of the evidence by itself. And that has always been frustrating, because if I remember, I looked at the American Heart Guidelines, you'll see less than 10% of the guidelines are based on what we consider moderate evidence, but they are strongly recommended. At the same time, you'll find probably 1 or 2% is based on hard evidence, but also strongly recommended. And you also find a lot of opinions that you will find that will be strongly recommended. So unfortunately, unless you have some kind of a relatively objective way of classifying the quality of this information, to us as users, it becomes very difficult. How can you say, if they make a strong recommendation, you follow it, but need not be based on hard enough evidence. That way, the subjectivity goes out of the grade recommendations.
Dr. Ram, we all know that it is a very recent development which has happened last 4 or 5 years that these grade recommendations are coming. And we also know that in 2021, our surviving sepsis guideline has also changed their pattern, and now they have come up with the grading of recommendation for a different kind of investigations, procedures, or therapies which we like to give. What do you say that all those things which we have done till date, uh, in front of grade, they don't carry any kind of importance as far as guideline and recommendations are concerned?
It is very difficult to completely deny that. Obviously, they are based on a reasonable expert opinion, and naturally, they do have some degree of a weight in terms of the recommendations. But I think we need to recognize that there is a huge amount of subjectivity to the way in which these recommendations were made. And as a consequence, I think we have to be very cautious about it. If I remember, there is at least one set of guidelines that have been looked at, nutrition guidelines, for instance, which are based dominantly on opinions rather than on hard evidence. And when people test whether you follow this evidence or not, the outcomes don't seem to be very significantly changed. So some of these recommendations that were made in the past were very subjective and naturally were a reflection of the opinions of the individuals who made those recommendations, then unlikely that they will translate into a genuine difference in terms of outcome. So that is my feeling about it. It's not like we can dismiss it off completely, but we certainly give it a lot less weightage than we do for something with the great recommendations.
So I would like to ask you, Dr. Kulkarni, so what is the implication of these recommendations for the physician as well as the patient?
So when the authors of guidelines look at the evidence, and we know the hierarchy of the evidence, that randomized control trial is the top, followed by a meta-analysis, then observational study, then case cohort studies, and it also depends on the number, type of disease, etc., and lastly case series. So depending on the type of evidence available, the guideline maker will see what is the type and quality of evidence available. So if the evidence is strong, they will make a strong recommendation, and either they will say weak recommendation or they will write we suggest. Now when they make a strong suggestion or strong recommendation, that generally for the clinician means that the intervention that the guideline author is writing about is more likely to benefit the patient than can cause harm. When you say weak recommendation or a suggestion, then either the person who is writing the guidelines is not sure, or the evidence is equivocal in the sense that the patient may benefit, patient may be harmed, and it is up to the clinician then at the bedside to decide which type of patient, in which type of patient he is going to use that particular intervention. For the patient, if the patients are very smart now, they will go through Google and they will look at the strong recommendation. Even if they don't do that, it just basically means that most patients are likely to accept the benefits that they are going to get because of a particular intervention, and they will agree to be party to that intervention with the fact in the back of their mind that they are less likely to be harmed as against the suggestion or a weak recommendation, where they will have to weigh the benefits and risks again in conjunction with the clinician who is suggesting the therapeutic option to them.
Yes, sir. And so when we lack either strong or weak recommendation, the great guidelines give us good practice statements. So again, that becomes a very subjective.
So where the person who writes the guideline, they will write it in different manners. So good practice point, your useful practice point,
practice,
and so on and so forth. Essentially, either there is no evidence or the evidence is equivocal, and then it's expert opinion, which, like Dr. Rajgopalan is saying, that then uh, it is up to the person who is treating who can decide what to do, because even the guideline makers are not sure.
Could I add one thing to that? I mean, if you're looking at guidelines without the grade recommendations, they were so dependent on the quality of the individual who was interpreting it.
Yes.
So very strongly, they expect you to know the way in which you can judge the quality of the papers, even when they make recommendations that are extremely variable. So unfortunately, most of us either don't have the ability or the time to interpret this, that if somebody makes a recommendation from a big society, you automatically presume that that is what we need to follow. And that unfortunately creates a whole big of a problem for, in terms of its
So training in
application.
grade
Yeah.
methodology is of primary importance.
I think it is very useful. It's almost like taking it through a journal club of some kind and critiquing every single article that provides the evidence, and ultimately trying to suggest that we should look at the best quality of data before we make any kind of a judgment on the treatment.
So, for example, apart from this, in our practice, what is also going to happen is the cost of the intervention is also going to be thrown into the picture, because if you have something which is cheap, for example, vitamin C injectable, and there is no great evidence to support it, now that we know that it causes harm, we will not use it probably, but something which is cheap, even if there is no strong evidence to back it up, the clinician might actually do it, saying that there is no harm and it is cheap and why don't I do it, versus something which is very costly. Say for example, we used to have Zygris, which is very costly, and then even if there is a strong recommendation, if the patient can't afford it, we can't do it.
Dr. Ram, certainty of evidence, that is one thing on the basis of which this grade recommendation guides themselves.
Yeah.
So, less certain to a more certain state. So, how this methodology is used by this great technology?
As you probably see with the great technology, they go through, as I said, it's almost like they're doing a journal club and critiquing each single article to the kind of extent that we would be probably doing it. And they will look at issues, I can just read through the list of what I have, what they call risk of bias, imprecision, inconsistency, indirectness, and publication bias. Each of that is probably something that you do understand adds to the quality. But when they're talking about it, when they talk about the risk of bias, it is absolutely worthwhile looking at it and saying, yes, we understand the bias is likely to be greater in something that comes out of a non-randomized controlled trial. It is likely to be very high in opinion-based, or case series kind of situations where they're giving you a recommendation. So obviously, the first issue that we need to look at in terms of the risk of bias is really qualifying the nature of the evidence that is being provided in terms of the quality of the studies. And obviously, it also becomes equally important. Shall I just go through this whole list?
Yes,
Okay. That besides the risk of bias, we need to have a precise enough estimate of the magnitude of the effect. Obviously, very small clinical trials which are looking at small differences are unlikely to be able to give a certainty about whether this benefit is there or not. And as a consequence, the size of the trial is quite relevant, and the larger the trial and the larger the effect, you're more likely to believe something like that.
So that brings up the certainty of evidence.
Yeah, it raises your certainty to a greater extent.
The magnitude of the effect.
I don't know whether I'm going on to the next question when I'm talking about the certainty of evidence, but effectively I feel it's a crossover.
Yeah.
So it does improve the quality of the evidence, first if it comes from a big randomized controlled trial, and if it is reasonably precise in terms of what it is ultimately
so can
estimating.
you, sir, just in simple terms for our viewers, can you expound on the term precision? How do you know?
Well, okay, you're putting me in a little bit of a bind over here. But precision is the ability to make a judgment of the benefit of a therapy in comparison to a non-therapy with a certain degree of accuracy. Okay, obviously we understand that when we are deriving this from clinical trials, we are not looking at every individual in the population. We are looking at samples of individuals, and when we look at samples of individuals, the estimate of the benefit is likely to be only a crude range.
The
It
way
is unlikely.
define the confidence interval.
Yeah, it
Yes.
effectively
So the
becomes
absolute
something that
effect
requires a
and the
confidence interval.
yes.
Yeah.
And when it is a small kind of number, the confidence
Yeah.
interval is excessively large, and unfortunately will not allow us to differentiate the even a benefit when the benefit is very small. So for a small benefit to be detected and for a process to be detected accurately, you need large numbers. I don't know whether I'm being very accurate. I
No,
think
no.
I'm a
Yes.
little boiled down
No,
into
no.
my own.
Actually,
No,
I
I
think
think
this is the way the people
yes,
will
we-
understand
Yeah.
because
No, the other problem is, and fortunately, there are many ways you can learn about the type and quality of evidence and how to assess the randomized control trials. And the person who is making the guidelines will make sure,
Yeah.
hopefully, that even if the trial is large and it has um, a strong positive effect of a particular intervention, it is very important that you look at the individual patient when you apply the results of a trial, because
Definitely.
that type of patient may have been excluded from that trial when that person is making those guidelines. So, if your patient fits the exclusion criteria of that trial, however strong the recommendation might be, it is quite useless for that particular patient. So, it is a guideline is fine, but it strongly recommends something.
Or it may not be
It may not
applicable
be
to that
relevant to
particular
your
setup,
patient.
to the maybe a
So, yes. So, most of your work is done by the person who or the group of people who have made the guidelines. It is the clinician's job to see whether these guidelines are pertinent to the person or the patient in question in whom you are treating.
Yeah.
And
Or-
I am sure that is where the assessment of the evidence or the clinical judgment comes into picture, which Dr. Rajgopalan was talking about some time back when he said the bias. So, it is not only bias of the person who is making the recommendation, it is also the ability of the clinician to interpret the patient's condition and whether the treatment is applicable to him or not.
Dr. Ram, another important thing which comes under this grade methodology is indirectness.
Yeah.
Yes, they try to avoid this indirectness because that makes the evidence less certain. So, will you expand on this indirectness
No, I
a little
think
bit
that was
for the knowledge?
that is effectively what Atul
Yeah.
was actually talking
Yes.
about.
Yes.
That extrapolatability is the word you probably like to
Yes.
use.
Yes.
That just because it has been shown in a clinical trial, it doesn't necessarily mean that it applies to your
Your
patient
patient.
directly. It may be an indirect allusion to the fact that it may be beneficial in the patients that were looked at, particularly in the form of the trial. So, if I'm going to look at Western data and then they say they show me an efficacy, for me to be very careful about the extrapolation is going to be
Yes.
very important. And somehow that has to be taken into consideration, especially if you're writing guidelines for India. We can't be writing guidelines the same way they're writing for a Western country, primarily because the data that is derived from a Western country doesn't apply directly to our patients. I think that degree of indirectness is something that we should assess in a grade recommendation. And I think that probably is one of the strongest points I feel. The rest of it is a question of quality of the
randomized
the control
trial.
trial
Yes.
itself, which many of us may be having a little bit of a skill. But this, I think, we need to look at in terms of the indirectness of the
Dr.
recommendation.
Atul, you are our chairman of this journal ISCCM. Another important thing which is there in that grading system is the publication bias. So, what exactly is publication bias? Can you really focus on it?
Yes. So, publication bias is, just to give an example, is that you are looking at some intervention. The studies which are positive tend to be accepted by the journal. So, the authors themselves were more likely to publish the studies, submit the studies for manuscripts for publication, and the editors are likely to accept it because you have intervened and something positive has come out of it. As against these studies, where the outcomes were negative, in the sense that for small example, you say that stroke volume variation is something which works. So most of the studies which say that stroke volume variation is very good for a patient who is undergoing this surgery, that surgery, etc., etc. And when we looked at this, the area under the curve was very good, and we could predict fluid responsiveness. At the same time, I might have done a trial where I did the same intervention, but I found that the predictive value of the test is not very good. So the person conducting the trial gets himself disappointed and does not submit a manuscript for publication. So that's called publication bias. And generally, when you do a systematic review or something, you do something called as a funnel plot, if I remember correctly,
Yep.
where you will see a hole on one side that negative trials are not published, and most of the trials which are positive are going to be published. And we should be aware of this, because this is going to affect almost every aspect of the patient management.
Dr. Ram?
Yeah.
Suppose I'm reading a guideline, okay. Now I see that it has been recommended as grade 1, grade 2, grade 3, grade 4 or whatever grade. So how should I adopt those kind of recommendations in my practice?
Okay.
Mm.
No, very
Suppose-
clearly.
uh,
Very clearly.
Because in between, because what I say, grade 1 is absolutely fine, okay, there is no problem accepting it.
No.
Grade 2 and grade 3, how to accept those
No,
kind of
could I be
recommendations?
very careful and say that if you're going to apply the grade methodology for this, we qualify the evidence not on a numerical value, but on whether it is based on what we call very low evidence, low
Weak.
or moderate or high
Moderate or
high
high.
kind of evidence. Okay, and that is very useful, because if it is moderate or high, the acceptability of that recommendation would be very fair. And here we are not using our subjectivity in terms of making an understanding of the decision, but rather we are basing it on the expert opinion. And in that sense, I feel that if you apply a grade recommendation and use that, I would rather follow anything that falls into a moderate or a high recommendation, as long as it is additionally qualified to see if it fits my patient population. Even though indirectness is part of what they will always assess, I would be very careful and say, did this guideline come from the Indian society, in which case the indirectness is likely to be less, or would I say this same guideline came from an American society where the indirectness is likely to be high, and my tendency to apply it will be a little different. So definitely that will also be the factor. But if it comes from an Indian guideline and they use the grade recommendation, okay, and they are doing it, I think I have a greater tendency to accept that kind of a guideline rather than something that is published by someone else.
Not just from country to country, but also from setup to setup. Maybe
Oh,
a
absolutely.
tertiary Apex Institute
I-
will have a better applicability of that.
Oh,
guideline
absolutely,
there is,
absolutely. I
So
think in
in
yeah.
our setup like India, we need to focus
it's not
on.
the applicability part, it's the part of the resource being available to you.
Yes.
Also,
So
yes.
you might say that a patient with cardiogenic shock will benefit from left ventricular assist device.
Or IBP.
But if you have no access
Ah.
to the device, then you obviously can't apply
Or
it to.
if people are not trained in that technique or
Yeah, so-
inadequate
so when
training
you say
and
resource, it can be either the hardware
or
or
the
human
human
resource,
resource.
not-
Yes, yes.
So,
So we
just
need to
having
keep
the
them on.
ECMO machine doesn't help.
Mean that the ECMO will
Somebody
help the
has to be
patient.
able to
Yeah.
do the ECMO as well.
Yes, yes.
Subjectiveness is one factor that is many a times comes while this. They say ki, okay, there are so many literatures on this, but none of them are so good so that we can directly go for a high level of recommendation. In those cases, the grade says that we take the opinions from different leaders of that particular specialty. And so how do you think that the kind of recommendation which comes on subjective basis, how should we consider them as a good recommendation or bad recommendation? How should we interpret that?
Very difficult when a subjective recommendation comes. Obviously, it is going to be a low grade recommendation. So in that sense, the routine application will be quite difficult. See, my concern about the grade recommendation is not the question of subjectivity, which will naturally be there in any kind of recommendation process. But the fact is, it is a very transparent process. The transparency is what adds to the strength of the grade recommendations overall. The reason in the past when somebody said, I don't believe in that recommendation, they never gave you a reason for it. Right now, you have an objective classification of the process itself. While the interpretation may be ultimately subjective, it at least tells you how the lines of thoughts were. Okay, so that you don't necessarily feel that you've been forced a specific point of view. And in that way, I think the grade recommendations are very useful. I think we need to eliminate or make that differentiation between the subjectivity, which is naturally going to be there,
Yes.
and the transparency with which it is being provided, which allows you to analyze that subjectivity and make a decision about the use or not use.
What about trials which are not randomized, Dr. Kulkarni? So can we have certain markers that brings up the evidence in non-randomized studies?
So obviously they are down the ladder from a randomized control trial. The non-randomization, the problem is nothing is wrong with the trial. The problem is that randomization is supposed to take care of equal distribution of all confounding factors, and then you will have a selection bias, in the sense that it will introduce the selection bias, because suppose I have some patients in my unit and Dr. Rajgopalan has some patients in his unit. We are both recruiting patients from that same trial, and I favor a particular treatment. I will put that patient in that arm because I think the patient will benefit from that, while he might do exact opposite, and then therefore there will be selection bias. The same thing can happen in a trial which is randomized but not blinded. Now it is sometimes impossible to blind the intervention. For example, you want to try, say, propofol versus ketamine. I mean, they look different, and there is absolutely, or it's extremely difficult to actually blind the clinician to what you are using. So if you have a non-randomized trial, or if you have a randomized trial of interventions which cannot be blinded, then your outcome should be objective. If the outcomes are not subjective and they are very objective and precisely defined, then that trial can still be a good trial and not necessarily be a bad trial, and you can take it as a strong evidence. So hopefully when the guideline makers look at the decide the grade of evidence, they take into consideration all these factors.
No, but I would probably say something a little different. The grade doesn't give you that kind of flexibility to make a different recommendation. It says qualify the nature of the trials and make a hard recommendation about whether the evidence is strong or weak. And if you see a non-randomized control trial, as much as we appreciate that it may be difficult to make a randomized control trial, they will definitely not give it a high enough grade. And definitely that would be the way in which we need to look at this data. I think we can't go around and say because it is not possible that we should go ahead and accept
No, so
it.
they will put it as a moderate.
They will put it down. They will not put it as a moderate.
High or a moderate. They will put it as a low quality evidence.
Definitely, and
so
that is what
the guideline maker is considered to supposed to consider all these factors.
Grade is coming up with new tools, like the minor tools.
Yeah.
To basically extract evidence from non-randomized studies. Also, the dose effect relationship and the magnitude of effect. These are significant, and I think that will help us in deriving substantial evidence from the non-randomized studies.
As much as I can appreciate the dose-response relationship, that it definitely adds to the strength of the information, I have a problem about the magnitude of effect. Because almost always, a large magnitude is usually the first data that is always printed. Okay? Because of if there's a new therapy, unless I show a large magnitude in terms of the effect, it is unlikely it will come to publication. It may be part of a indirect way of publication bias. So generally, I am always very skeptical about a trial that shows a large magnitude, primarily because it will regress to the mean. You will probably see smaller and smaller effects with subsequent studies, or it is probably an artifact. Okay, and particularly if it is a biologically infeasible kind of a difference. So you say, I'm treating ARDS with the administration of steroid, and I say I have a 40% difference in mortality, I would be extremely skeptical. As much as the size of the benefit seems to be very large, it is not biologically feasible. So that is my concern about the grade methodology in general.
Considering the magnitude.
No, it also looks at the methodology alone, but it doesn't look back at the science.
But if there is a big magnitude of effect, then the idea is that maybe there is at least a small effect, and maybe our patients may benefit.
Or not necessarily, or maybe it is completely artifactual. No, my own argument is that is quite important for us to understand that. The grade recommendations will be very strong for a large magnitude of effect.
Yes.
But the fact is, if the science behind it says this is impossible for it to occur, it is very, it won't come into the grade recommendations, and I think that is one of the most important.
What I think Dr. Rajgopal is getting at is that is there a biological plausibility for that effect that grade won't consider?
No, I'm going actually a little higher. I'm trying to say that the grade recommendations are only based on the methodology or the quality of the study, and they are not in any way an exploration of the underlying science.
Obviously.
Okay, I think it is quite important, and I think it is quite important to recognize that as a huge limitation. Just because a grade recommendation is made, it doesn't naturally become an acceptable fact, if you might want to say that. And I would be very careful about the size of the...
Dr. Ram, I think we have some shortage of time, so we'll finish up. Last thing which I think is very important as far as our society is concerned, how do you think that we should train our residents and upcoming critical care practitioners about this grade system, so that in future we can completely adopt this system for our all purposes? Well, how we can do the training part, how can consider it?
The training actually comes through much of their educational period.
Yes.
I think if you can emphasize the importance of the quality of these studies in a journal club kind of a structure, where you teach them the importance of randomized controlled trials, where you teach them the importance of the magnitude of the difference, the ability to make precise versus imprecise decisions. I think all that is absolutely essential for somebody to start with. But obviously we understand that most of us don't have the ability to read every bit of literature, that we effectively hope that somebody will do that and will summarize it and provide us with guidelines that can be graded in an honest kind of a way.
Do you think that we can do some workshop kind of thing so that people can understand how to adopt grade?
Yeah, I'm sure you can give the workshop about grade to individuals who understand the implications of randomized controlled trials, the quality and quality issues related to clinical studies. But that to impart that baseline education is a much longer drawn process. It has to be a part of their education as an intensivist right from their beginning. I think it requires a combination process. You can definitely do guidelines on grade.
I think teaching students or trainees about grade recommendation is probably towards the latter part of the curriculum.
Absolutely.
I would rather start teaching them about what is a randomized control trial and why do we need
methodologies
and research methodology, which ISCCM started doing quite some time back actually.
Yes, but
so the unfortunate part is not that. Unfortunate part is that we have workshops which are not very well attended. So unless there is a training from the undergraduate days to make everyone get interested in research, we'll have to just continue to run these workshops. And
so I think we have finished with our time. So I thank Dr. Ram Rajgopalan, Dr. Atul Kulkarni and Dr. Sulagna for joining this studio session of Indian Society of Critical Care Medicine. And I hope that at least some message might have gone to the audience so that they can use it while they are reading an article, this importance of grade system. Thank you very much.
Thank you so
Thank
much.
you.
Thank you.
Well, good afternoon, everyone. We are again here back in the studio. I am Dr. Ranajit Chatterjee. I am a Chief Medical Officer and the head of the Department of Critical Care in Swami Dayanand Hospital in Delhi. And we are going to discuss here today on fluids and early vasopressors in vasodilatory shock. With me is Dr. Ahsina Jahan Lopa, and she is our consultant in Bangladesh, senior critical care specialist, and I give it to Lopa to introduce our eminent panelists.
Thank you, Dr. Ranajit Chatterjee, for your kind introduction. This is my pleasure to be here with these eminent faculties around the globe. So, thank you everyone to be there in the Critical Care Studio, which is the first ever concept in ISCCM. So, I want to introduce my interview with us today. So first of all, I will go to Professor Jean-Louis Table, actually who doesn't need any introduction, but I must say that he is the father of fluid responsiveness and vasopressor, widely acclaimed in intensive care. So recently he is also working as a scientific chair in Congress committee, and also he is the professor of therapeutics and critical care medicine in Paris Cergy University, France, and his area of interest is hemodynamics, fluid and vasopressor therapy in septic shock, fluid responsiveness tests. And also I would like to introduce Dr. Pradeep Rangappa, who is a big academician in working in India and also in abroad, and we all know that he has a very big fan follower in his YouTube, and every day we listen to his great lectures. So currently he is working as intensive care specialist in Manipal Hospital, Yashwantpur, and his area of interest is all dimensions of intensive care history. So welcoming you all, Professor Tebul and Dr. Pradeep Rangappa. So over to you, Dr. Ranajit.
Well, as you know, Dr. Pradeep and Dr. Tebul, that distributic shock is one of the commonest form of shocks that we are regularly, basically, we are getting it, encountering it in the critical care practice. There is widespread vasodilatation, not only the venous level, but also in the arterial vasculature. And for that, we also know that the duration of hypotension and the amount of hypotension, the severity of the hypotension, both basically increases mortality. So we have to increase our mean arterial pressure as quickly as possible. And in order to achieve that, the two main pillars of treatment are fluids and the vasoactive agents. So the first question will be asked by Dr. Lopa to Dr. Tebul, please.
Yeah. So Dr. Tebul, we are very excited to hear from you. Actually, this is a very big, what can I say, interest of all of us who are working in critical care. That is what amount of fluid, where from this 30 ml per kg concept came. Do you agree with this?
Thank you for your question. Very interesting question. I don't fully agree with this number. I agree with the fact that vasodilatory shock, especially septic shock, is always associated with hypovolemia. Always associated with hypovolemia. So we need to give fluids early and urgently. The issue is that a fixed number, just individualized on the weight of the patient, does not seem to me very judicious, because hypovolemia is very variable among septic patients. Sometimes you have a very marked hypovolemia because of external fluid losses, internal fluid losses, for example, in case of abdominal sepsis, and we need a lot of fluids. We need to give a lot of fluids. Sometimes you have a septic shock due to pneumonia, community-acquired pneumonia, and sometimes in old patients or in patients with cardiovascular comorbidities. These patients are not as hypovolemic as the first category of patients. Therefore, giving the same volume of fluids to every patient is not, my opinion, appropriate. It's better to individualize the initial fluid therapy and to look at the persistence or the disappearance of signs of shock.
Well, just that means you are telling that every patient is different. The heterogeneity of the patients has to be seen, and you have to individualize the patients. It is this 30 ml per kg is not an absolute number. It is it can vary from patient to patient. Dr. Pradeep, just to add on to this, can you highlight certain recent articles that has come up on this, basically whether to restrict this fluid, this 30 ml per kg, as Dr. Tebul is telling, is really quite not being accepted by many of us.
Yeah. Thank you, Dr. Ranajit. So I agree with Tabul, yes and no. The reason yes is sepsis guidelines does say 30 ml initially, but what we are terribly worried is a cumulative balance that tends to happen over course of time. So they have analyzed big data from sepsis cohort of the patients, and one of the good analysis that happened was from the VAST data that happened from Canadian group, where they showed if they have a cumulative balance at day 4 in sepsis cohort, these patients had higher mortality. So that is something which we have understood. And the SOAP investigators, again from France, I think they have looked into that subgroup, and they have also seen that a positive fluid balance at day 3 increased 60-day mortality. So following which, then there was a increased enthusiasm to see that giving more fluids and having this fluid accumulating in a patient is leading to more problems, and that is what led to few newer trials that came. And I think one of the important trials that we should possibly reflect, two trials actually, are the RIFS trial and the sensor trial that happened. So the RIFS trial, actually they did a good randomized controlled trial, and they had a restrictive and liberal in sepsis group. And what interestingly they did, obviously did not have a mortality, but the duration of mechanical ventilation was significantly less. And all these trials that we are talking is only in sepsis patients in first 72 hours to 96 hours, trying to see whether if we restrict versus little being liberal, and cumulative balance having a bearing on the outcomes has been demonstrated. And another one trial is the sensor trial. So that has also clearly shown that there is no benefit in having more fluid given in the early phase, and possibly we should restrict. And the sensor trial is mainly to compare early norepinephrine and fluids as a choice, and they found that early norepinephrine, rather than filling them incessantly, led to better secondary end variables outcome. So these are some of the evidence that we have. So going by it, we all possibly have to be little judicious. And in fact, now we have looked at the sort of cumulative fluid that was given in the process trial, ARISE trial, and even that we are coming down on the fluids. The mean sort of a fluid they got was 168 ml per kg, 160 to 165. So we are even looking at whether could that be minimized to influence the outcomes. So this is where we are with regards to the evidence.
All right. So I think that's quite clear now, and quite fascinating, Dr. Lopa, isn't it?
Yes.
That both of the panelists are now telling to the community that not this number game has not to be followed, and we have to individualize the patients. Now it has been also proved by certain data. So before Lopa, yes, Dr. Tebul want to comment on something.
Yes, I want just to add something. Do you know what is the total plasma volume in a normal person?
Yeah.
It is around 45 ml per kilogram, meaning that 30 ml per kilogram during the first 3 hours, it's a lot for some patients. So this is why I think that we have to individualize. Sometimes it's not enough, of course. So why to give the same amount to everyone? It is more than half of the total plasma volume. And sometimes hypovolemia is not so pronounced. This is why we have to tailor the therapy.
All right. So just as we have to give fluids, that we have to do, isn't it? So which fluids? Whether it is normal saline or it is balanced salt solutions or something else, which fluids?
So I think that's a good question. So I think even see whatever answers we provide for these questions, we need to look into the science and the data that has evolved. So initially there was sort of an enthusiasm to lean towards balanced solutions, and this predominantly came from few trials like SMART trial and SPLIT trial and so on and so forth, where there was an increasing enthusiasm saying chloride is bad and more chloride solutions lead to increase in the acute kidney injury. So there was a move towards going towards balanced fluids. But the recent evidence, which predominantly came from BASICS trial, which came from Brazil, and then there was a PLUS trial, which came from US group. So these two trials basically have clearly shown in a large subset of the patients, where it really doesn't hugely matter, because they looked at a lot of endpoints, and they did compare saline and balanced solution, and they did see that saline is as good as balanced solution. Having said that, in traumatic brain injury, I think this is a subset of patients where in fact they showed that saline may be more desirable as compared to the balanced solution because that appeared to be more favorable.
So again, individualization, but I don't think, Dr. Tibul, that hardly 500 or 1000 ml of fluid will matter whether you give saline or balanced salt solution.
Yes, it doesn't matter because anyway, if you tailor the therapy to the needs of the patients, finally you don't give so much fluid.
Okay.
And it does not matter if you give balance or unbalanced. Of course, if you give more because the patient needs more, so maybe you have to think about this chloride accumulation. But at the beginning, because we are at the beginning, we are starting fluid resuscitation, I think this is not an issue if you give balanced or unbalanced.
Okay. So Professor Tibul, again to you, that is, when will you advise your patient to start monitoring on fluid responsiveness?
This is a very interesting question because when we start fluid resuscitation, we have not the necessity to monitor fluid responsiveness. We give fluid because the patient is hypovolemic by definition if it's septic due to reduced water intake the days before, due to fever, etc. Hypovolemia is present. So it is not important to think about fluid responsiveness at the beginning, but after some time, after maybe I would say 1 hour, you have to look at fluid responsiveness because some patients are not fluid responsive after 1 hour, and there are very interesting data published in the literature. The Andromeda shock study, for example, published in the JAMA 3 years ago, clearly showed that after some time, patients can be fluid unresponsive in spite being in shock. And therefore, this is after 1 hour, sometime 45 minutes, 60 minutes, whatever. You have to define if the patient is fluid responsive or not. And this is important to perform tests at that time. So I summarize, not at the beginning, but after the first or second fluid boluses.
Can I throw a concept here? So initially when we have a clear clinical indicators that the shock is prevailing and it is very evident, so we really don't need these tools. But my question to possibly, if I can ask Tabul, once you have this fluid responsive test put in and we say that he's adequately volume, but still there are indices of a lot of microcirculatory dysfunction where you have very evident features of mottling. So what do you do in that situation, Dr. Tabul? What sort of a clinical tool or a hemodynamic tool would you use in such situation arises?
Yes, you are totally right. We have many situations to deal with where you give fluid, the patient responds in terms of fluid responsiveness test. It can be fluid unresponsive after some fluid, but shock persists with some signs of hypoperfusion, skin hypoperfusion, and maybe
and lactate going up.
Lactate going up, tissue hypoperfusion. So in this situation, of course, we need to first to think about the MAP target. Maybe the MAP target is not the optimal one, and we have to think about another optimal MAP target. We also need to look at the source control, because sometimes when the patient does not respond to the therapy, it is because you did not control the infection. So you have to think about some drainage of abscesses, some change in antibiotics, of course, etc., etc. You have to think about this. Not to say, okay, microcirculation is impaired, I cannot do anything. No, you have to do something, and you have to rethink about your initial strategy.
All right. So that's a very nice way of explaining it. As Tabul, I'll ask this question to you specifically, because you are the pioneer of measuring the fluid responsiveness. You have given us the passive leg raising test. But many of us do not do it properly. Can you just tell the audience exactly how to do passive leg raising test and what exactly to measure after that?
Yeah. So again, we perform PLR, passive agonizing test, only if the patient is still in shock and the patient does not respond to the initial therapy. So we need to look at the presence of responsiveness again. So PLR is the simpler test to perform because you have just to change the position of the bed of the patient. Normally the patient in the ICU is in the semi-recumbent position. This is a normal position. And so you have to move the bed in order to have the legs elevated at 45 degrees and the trunk and the head horizontal. So you have not to change the angle of the hip. You just move the bed. And therefore, you can create some mobilization of venous blood from the legs compartment, but also from the abdominal compartment towards the intrathoracic compartment. This is why PLR mimics a preload challenge, free challenge. Of course, you don't give any drop of fluid. The issue is that you have to assess the hemodynamic effects of this maneuver. Normally, the best way to do is to look at cardiac output. Sometimes you have no cardiac output device in place. And we can use echocardiography if we have a machine. And if you do this, you have to look at the change in velocity time integral, which is a marker of stroke volume. Otherwise, it is more complicated. Something which is important, and maybe your question is wanted to address this point. The patient should not be stressed by this maneuver. You should not cause any harm, any pain, any stress to the patient. Otherwise, you could have an increase in cardiac output due to sympathetic stimulation and not due to passive mobilization of the blood. To be sure that your test is reliable, you have to look at heart rate during the maneuver. If heart rate does not increase, it means that sympathetic stimulation is not so strong, and you can rely on the results of the test. This is very important.
Yeah.
So such a big relevance here, and the main point that the audience should see, you have to move the bed, Lopa,
Yes.
and you don't have to move the patient.
Yes.
That's what he is saying. And normally we move the patient and not the bed. This has to be understood properly.
Yes. Yeah. So my question to Dr. Pradeep Rangappa, if at all to start vasoactive substance, when will you start and why to start?
Yeah, I think this is fairly intuitive question that before our thought was that we need to adequately volume resuscitate and put in measures to make sure that they are no longer volume responsiveness, and then you start the fluid. I think this has been our conventional thought process. This thought has been challenged because we have reasonably good data. So I think there was 2 meta-analyses, one from Australia and China, which showed that delaying the initiation of vasopressors, trying to keep on adjusting, because I think the macro fluid bolus that has been given based on clinical endpoints seems reasonable. But trying to tweak this micro fluid challenges later on to absolutely make sure that they are no longer fluid responsiveness, that may delay the initiation of vasopressors, and we do not want that. And that is where the data from this meta-analysis from Australia, which has come, Marimatsu et al. And Bai et al. From China, and the most recent trial, which is a sensor trial, which is published in 2019 in AJRCC. This was a very good trial. So they did a trial in 320 patients, randomized between early norepinephrine and the fluids. And they did see that early norepinephrine had a better shock reversal, and some of the secondary endpoints improvement was there. And the 28-day mortality, although was no benefit, but the risk of pulmonary edema and the duration of ventilation was less. So which tells us that possibly we should start vasopressors little early on, concurrent with your test for the fluid responsiveness, and possibly within 6 hours appears reasonable if you have adequately initially done the macro resuscitation based on the clinical endpoints. That would be my thoughts.
So anything you want to add, Dr. Table, because what are the benefits you think that we are starting the vasoactive substance?
I fully agree. We have to give norepinephrine early. We are talking about vasodilatory shock. definition, there is vasodilation.
Yes.
If you give only fluid, you cannot restore vascular tone because fluid is not a vasoconstrictor. And therefore, if you want to be active on the vascular tone, you need a vasoconstrictor. This is so obvious for me, so obvious. I don't understand why for years and years and years we were reluctant to give norepinephrine early, and we waited for hours and hours before, and we gave a lot of fluid. I experienced this in the past. And so, and now I defend the position of giving norepinephrine early because it is a vasodilatory shock first, and also we need, as you said, Dr. Ranijit, that we have to correct hypotension very quickly when hypotension is severe, and therefore the best way is to give vasopressors. And to finish, I look at the diastolic arterial pressure. I look at the diastolic arterial pressure because it is a good marker of vascular tone. It is not the only determinant, of course. Nevertheless, vascular tone is not the only determinant of diastolic arterial pressure, but it is a main determinant. And therefore, if it is low, it means that vascular tone is depressed. And especially in case of tachycardia. Because normally when you have tachycardia, you should have a higher than normal diastolic arterial pressure because of the reduced diastolic time. And therefore, if you observe low diastolic pressure in presence of tachycardia, you should think that the vascular depression is very, very pronounced, and you should give a vasopressor urgently.
So that's a very clear idea. That is tachycardia, but still the diastolic blood pressure is quite low, maybe below 40. Don't wait. Start your vasopressor as well. And which
if I may just add to what Dr. Tabula said, and it is importantly recognized that episodes of hypotension also has a very deleterious effect on the organ dysfunction. So we really do not want too much of hypotensive episodes, and many good studies have been done where a hypotension duration is very bad, and we don't want to allow episodic hypotensions. So that's where this initiation of early norepinephrine would be beneficial in avoiding that hypotensive episodes, which possibly fluid will not be able to do it.
Okay. So Dr. Tebul, again to you. Which vasopressor?
Oh, there is no doubt about this, and there is an agreement between everyone about the use of norepinephrine. You know that in the past we used dopamine, and I used dopamine in the past, and we switched to norepinephrine. It is a better agent for the vascular tone. It is less. It provokes less tachycardia, less tachyarrhythmia than dopamine. So there is no doubt about the use of norepinephrine. I just want to say something. Recently, the Surviving Sepsis Campaign guidelines now stated that it is possible and not so dangerous to use norepinephrine using a peripheral access, not only a central venous access. And therefore, this can encourage to start norepinephrine earlier than in the past. Because there are some data in the literature showing that finally, even if the patient receives norepinephrine peripherally, the risk of extravasation of the product, of the substance, in the area around the skin, around the infusion, is not very high, very low. And in addition, even when extravasation occurs, there is no risk of any any complication, and no need to have a medical or surgical intervention for this. And there are a lot of data now we have, and this is a way to start norepinephrine earlier.
So, when do you consider adding a second vasopressor, Dr. Pradeep, and which one?
Yeah, I think this is fairly logical in our clinical practice that despite obviously the primary thing is to make sure that we have addressed the primary pathology and we have done dynamic fluid responsiveness tests and tried to determine that there is no more fluid responsiveness, and you corrected the underlying condition, done the source control, still your vasopressor, something is not right. So adding A second vasopressor would possibly be a situation when there is an escalating dose of the norepinephrine that is happening, despite. So it's always comes with an underpinning that despite having done all the tests for your fluid responsiveness, administrating appropriate antibiotics, doing the source control, and looking at any other reversible pathology, even looking at the cardiac condition, whether because increasingly it's recognized very early on you have septic cardiomyopathy. So having assessed the cardiac function of all these have been looked into, and there is no other reversible component, no cardiac component, then I would start second vasopressor, and vasopressin would be the second choice, drug of choice at this, because we don't have many options, honestly. You know, you have only dopamine, I mean, which is again, we can discuss it later. So you have other drugs like ephedrine, phenylephrine, which are not the drugs that you would consider. So if it is only vasopressors, we have very limited choice. So vasopressin would be the second choice.
Okay, so any comment about to make the noradrenaline and its doses accordingly?
No, I fully agree. I fully agree. Sometimes we need a second vasopressor, and vasopressin is the best second vasopressor. Even if there is no strong evidence in the literature about the need of giving vasopressin, there are a lot of studies now and showing no benefit, but it seems logical. It seems logical to add a vasopressin when you are escalating the dose of norepinephrine, because at the end of the day, you could have very high doses and you have some risk of cardiomyopathy, as you said, but also many other risks. And so it is better to minimize the risk by giving two drugs, because if you give vasopressin, you can reduce sometimes the dose of norepinephrine. This could be beneficial. Another thing, after some hours, if in spite of the administration of vasopressin at a fixed dose, 0.03 units per minute, which is recommended by the ISCCM guidelines, that we agree, because with this dose, you can minimize the adverse events. If after this, you still have refractory hypotension, this could be a good opportunity to give steroids. Steroids in order to reverse shock, to make more active norepinephrine on the vascular, on the vessels, on the receptors. And this is now recommended by or suggested by the Soaring Seas campaign, and I agree about this. But don't do this at the beginning, after 4 to 6 hours, if the patient does not respond sufficiently in terms of blood pressure.
All right, so that is quite clear now that we add non-adrenaline, and when we reach a ceiling of non-adrenaline, we start vasopressin, we give at a dose of 0.03 units, and once it's still not coming down, we'll think of starting steroids maybe within 4 to 6 hours of time. But if you see the Surviving Sepsis campaign since 2004 onwards, 2004 the vasopressor of choice was dopamine, 2008 it was dopamine, 2010 the SOAP trial came, and from that it changed everything, came to start, non-adrenaline started taking the front seat. What about dopamine, the poor dopamine, it is still there?
No, I think that dopamine now is suggested only if you have bradycardia. That's it.
So hypotension with bradycardia?
Yeah, but it is an exceptional situation, as you know.
I think the message has to go strong and loud here about dopamine. Because I think there has enough data now, the SOAP investigators, as you rightly said, so they have done a sub-analysis in different types of shock. Because when we look at the usage of dopamine, it's not common amongst intensivists, but possibly it is still nephrology colleagues may be using it, and cardiology colleagues. And the SOAP study clearly showed the patients who were having cardiogenic element for the shock, in fact, they did worse off actually, because which means to say that if you have a cardiac component also, dopamine is very bad. And in nephrology, where dopamine was being used as a renal protective to prevent acute, which has become a myth now. So there has been in fact studies done that which has shown that it in fact worsens renal perfusion and it can worsen AKI. Which was shown by Canadian authors. So dopamine is really a drug which should be avoided, except as you rightly said, maybe in select group where there is a bradycardia, but otherwise, all in all, the data, the signals are pointing towards harmful effects of dopamine, even if there is an underlying cardiac condition and the acute kidney injury component.
Great. Yeah. But suppose in the village, of India, you don't have non-adrenaline, you don't have adrenaline, you have dopamine. Will you start or will you not start?
Yeah, I mean, if that is a precarious situation you are in, so something is better than nothing, so you have no choice, isn't it? When you have a choice, we go
That's a
for
very nice
norepinephrine.
thing.
But if you do not have anything,
Then
then
you have
beggars
to-
cannot be choosers. So you have to go for
All
what
right.
is available.
So hopefully you are in a better state and,
Yes.
and you will get non-adrenaline in the deepest part of India and also in Bangladesh.
Yeah.
Your question, Lopa.
So yeah, Professor Tebul, when will you decide to add inotrope along with the noradrenaline? And
Inotrope.
how do you decide? Like
Inotrope.
Yeah.
Yes, this is a good question because you know that cardiac dysfunction may occur in septic shock in some cases. For example, at the beginning, you could have cardiac dysfunction in around 20% of cases. And also you can have cardiac dysfunction after some days, from the second day to third or fourth day. This is possible. If you follow the cardiac function using echocardiography, for example, you can sometimes discover this. And if you have cardiac dysfunction and still persistent shock, in spite of fluid therapy, in spite of what you think as optimal MAP, it is logical to give inotropes, but only if you have shock, only if you have the documented cardiac dysfunction. And if you had already given fluid and vasopressors, and the best choice is traditionally and still the butamine.
So just how do you basically document that cardiac dysfunction by the bedside? How do you see that cardiac dysfunction? By echocardiography, by something else?
Oh no, no.
Bedside.
We perform echo in my unit. We perform echo in every patient every day, and especially patients with shock, of course. And so this is why we sometimes discover a decrease in the left ventricular ejection fraction, for example, which is a good sign, even if it is not a marker, a pure marker of contractility, but it is a marker of systolic function. And if you have a low blood pressure, so a low afterload and a low LVF, it is necessarily due to decrease in contractility. And if you don't give dobutamine to a patient with shock, with documented decreased contractility, with enough vasopressors, with enough fluid, if you don't give dobutamine to this patient, forget dobutamine for the rest of your life.
Okay.
Yeah.
So
Yes.
Pradeep,
Can I
that
make a comment on
Yes.
this cardiac dysfunction, which is increasingly being recognized? So it would be of interest because I've given a talk on septic cardiomyopathy. So it is shown in 1984 was the first time they defined this term septic cardiomyopathy, and it is increasingly recognized that up to 60% of the sepsis patients have varying degree of cardiac dysfunction. And what is cardiac dysfunction? It's distinctly different from cardiac cause. And this is something which possibly all of us should get sensitized to. So as Tabul said, there is depressed myocardial contractility with depressed function. That is everyone knows. But what is important, which differentiates between septic cardiomyopathy and cardiogenic shock, is the filling pressure. So usually the septic cardiomyopathy have a normal filling pressure or a lower filling pressure, and this is shown to be due to improvement in the left LV compliance, which tends to adapt to this. And it is reversible. It is acute and reversible. So increasingly, the reason why only in 1984 it was coined that septic cardiomyopathy, because before that we were all relying on PA catheters to assess the cardiac function. So echocardiogram got increasingly utilized by intensivists. Maybe after that, now there are good number of studies which are suggesting that we should evaluate all our septic patients for cardiac dysfunction. And there are 3 good studies. So there is Wallet et al., Rhodes et al., and Kumar et al., who have done studies on use of dobutamine in septic shock with myocardial dysfunction. And these are very small studies, and they have used 5 to 10 micrograms per kg of dobutamine. And in fact, Kumar et al. Has used sequential dose 5, 10, and 15, and is looked at improvement in the left ventricular stroke index of more than 8.5 ml per meter squared as a response to dobutamine, because not everyone responds. So if there is a response to dobutamine at that dose, he did a small study in 23 patients, and 21 survived, where this, because septic cardiomyopathy shown to have a direct correlation with mortality. And he did show very clearly by using dobutamine in this dose where you monitor the left ventricular stroke index and see an improvement of 8.5, they did better. So there is evidence evolving. Maybe we should do a bigger studies.
All right. I just want to add, Dr. Tibul, I remember that you told us that if you see the pulse pressure being narrowing and your change in the delta carbon dioxide, that is the arterial and the venous carbon dioxide is high, even if you don't have echocardiography with you, that is the time you start dobutamine, because I am quite concerned about when exactly to start it.
Yes, if you have no echocardiography, it is better to look at some other signs. I fully agree. PC2 gap. PC2 gap, it is a good marker of the adequacy of cardiac output to metabolic needs. And therefore, if PC2 gap is high, probably cardiac output is high, and you have to do something. The best is to look at echo to be sure that you have cardiac dysfunction. But if you have a high PC2 gap, you have no echo, and you already gave fluid, etc., maybe it is. It could be dobutamine could be indicated. But a point is very important. You said is that not all patients respond to dobutamine because you have in a severe shock you have hyporesponsiveness of the beta-1 receptors, meaning that sometimes the patient does not respond. LV ejection fraction does not increase. LV stroke index does not increase. Cardiac output does not increase. This is why it is important to test dobutamine, to test for 30 minutes, for example. And you look at the effectiveness either by echo or by measurement of cardiac output or by measurement of PC2 gap, and you look at the tolerance. And sometimes you have to decrease or you have to stop the dobutamine because effectiveness is not there and the patient does not tolerate in terms of arrhythmias, tachycardia, etc. So it is better to stop. So when I use dobutamine, I always use dobutamine as a test. And I look at the patient, I look at the effectiveness, I look at the tolerance.
Okay, so a very important question, that is how do you wean vasopressors?
That's an interesting question.
I think it's an easy question.
How? when you achieve the target, you can stabilize the situation. And if the patient improves, because shock improves, because sepsis improves, because antibiotics are doing their job, you will see that the blood pressure will increase with the same dose of vasopressors. And this is time to start to decrease, to start to wean. Sometimes you cannot. Okay, you come again to the same dose, but you are just trying.
Yeah. But which one first? Suppose you are having non-adrenaline and vasopressin. Which one you first?
Which was in first? From expert.
That's still a question that comes from many people.
Yes. There is a lot of how to say controversial data in the literature. Some papers show that it is better to decrease first vasopressin, and some papers show that it is better to decrease first norepinephrine. I would prefer to decrease first norepinephrine because vasopressin is recommended at the fixed dose.
Yes.
Fixed dose.
Yes.
So if you use a fixed dose and you stop this dose, there is no vasopressin.
That's
if you start by
by
decreasing norepinephrine, you can look at the effects easily, and you can go back if it does not work. So what I do in my unit is to do in first norepinephrine. But again, in the literature, there are controversial data.
All right. So
yeah, we are shortage of time because we have to wrap up. So we have a very wonderful discussion today, but it's not enough time. But I want final comment from both of you. The Professor Table with you.
Final comment, I would say that septic shock, for example, because we talk about septic shock essentially, is a very complex shock state with different components: hypovolemia, decreased vascular tone, myocardial depression sometime, and the combination of these different components is different from one patient to another one. And therefore, this is why we need to monitor the patient. We need to test to see what is the most predominant component and to treat preferentially the most predominant component. But we should not forget the other components. And if we want to improve mortality, we have to take everything into account and to integrate all the variables. But there is a missing link, which is a microcirculation. And today we are not understanding what is a microcirculation. We have no good markers, easy markers, and we have not good treatments of microcirculation. This is why probably patients die sometimes, because we cannot, with our treatment, which is a traditional treatment, fluid, dobutamine, and vasopressors, we cannot treat all the patients.
So anything just from Pradeep?
Yeah, I think my take-home comments is, I think we come a long way. We understood, don't be overzealous with fluids and don't be uptight with what sort of fluids, whether balanced or salines. I think stick to saline remain basic. And please look into the cardiac component in someone who is non-responder. Increasingly, we are recognizing that cardiac dysfunction is present in a variable format in a sequential way, and we may be ignoring that. And microcirculation remains a challenge for us. And maybe there, optimizing cardiac dysfunction and tweaking it with a bit of a noradrenaline at a fixed dose, I think 5 to 10 is a good dose, may have a benefit in these patients. So we have to look into that domain. And starting early vasopressors is the way to go.
So thank you so much. Actually, that was a very refreshing type of discussion. Give fluids, individualize, start vasopressor early, start steroids after a particular amount of time, and try finding out the missing link, as Dr. Table has already told. Maybe in the next discussion when you do it, we may find the answer to that missing link. Thank you so much for your presence here, and thank you, Dr. Table and Dr. Pradeep, for your excellent discussion.
Thank you.
Thank you so much.
Good afternoon, everyone, and welcome to yet another fruitful discussion of Care 2023, where we are going to have a prestige panelists to discuss about planning to face the challenges of a future pandemic. And I'm Anushka Dilani. I'm an intensivist from Colombo, and here with me my colleague Dr. Pradeep Rangappa would be interviewing our prestigious panel. And we have here today, starting from the left-hand corner, Dr. Srinivas Samadevam. He's a chief intensivist from the Hospital Hyderabad. And then we have Professor Crinorio Pia Sivole. He is from San Filippo Neri Hospital, Rome. And then we have Dr. Adel Al-Sisi. He is the head of ICU department, a consultant intensivist from Prime Health Care Group.
Welcome.
And then we have Professor Flavia R. Machado. She is from the head of the critical care pain and anesthesia from Dore Medicine Intensive Care Hospital, Brazil. Sorry if I made any mistakes in introducing you. So yes.
So very good afternoon, everyone, friends. So I think today we are here because the wrath of pandemic is over, and we're all delighted to have esteemed panelists who are at the forefront of facing the pandemic and conquest and having having a victory over this pandemic. And we were at the front line. I think intensivists were really at the front line when it first hit us. So we really are here to see and engage as to what are the steps and measures that we have undertaken in this epidemic of COVID that happened, or a pandemic that happened, and how should we be better prepared for the future. I think that's what we are here to discuss. So we have literally panelists from every continent. I think Italy was hit the worst, and in fact all the signals, initial signals that came to the world was from Italy, and they are the best people to understand the sort of intensity, and it was quite frightening to see the type of signals that we are getting from Italy with regards to the deaths and the resource crunch that was happening there. So I would want to ask a question to Professor Quirino as to what are the lessons, hard lessons that has been learned at the cost of the human lives in Italy, because Italy really got hit and possibly they didn't have adequate time at that point of time to be well prepared for this sort of a wrath that hit them. Professor Quirino, your thoughts as to what are the hard lessons learned and what are the steps as a country in Italy that we should all be engaging and taking steps to mitigate this and face the future pandemics?
Very quickly, my recommendation is not to make the same mistake of the past pandemic, that was sit and see. The pandemic, the virus is more speeder than this technique. We must be very aggressive, and this was the main error that all our government did. Is like a disaster manager. This man doesn't wait the disaster to prepare something. We must be prepared before, otherwise we have a lack of devices as happen, lack of dresses, adequate dress, lack of intensive care, lack of everything.
So Professor Quirino, are there any specific intensive care steps that you would advise our listeners that we should be taking as intensive care specialists here?
Europe failed also in this. They show very clear. I am the coordinator of a European Healthcare Commission, and every country has the same policy about intensive care. So we have a country like in Italy that have no more bed, and like a country like Poland that have a free ICU bed. It is when you have a pandemic, it's like a tsunami. all the country need to collaborate with the same effort and with the same planning. So you require, like the General Secretary of the United Nations recommended during the last COVID meeting in G20 in Rome, okay, also with your Prime Minister, we need a strength central authority.
Thank you, Professor.
Yeah. Yes, and sorry about earlier. I have to also introduce Professor Subhash Acharya. He is from the Department of Critical Care Medicine, Institute of Medicine, Tribhuvan, University of Nepal. So, sir, I would like to ask you the next question, which is, what do you think if there is to be another pandemic? What are the key elements that you think we should be prepared with?
As we all know, Nepal is a very low resource country, and we were fortunate to some extent that during the first wave the COVID came a bit later. We had few months to prepare, like the first case that we got was like almost 3 months later, so we had some time to prepare, and the government was quick enough for the lockdown, and which I think was a good move to prepare the things and to build up the resources. But I think for the future, I would more recommend to focus on human resources. Human resources, that was the major challenge that we felt during the pandemics. As you all know, ICU is always scarce everywhere in a low resource country. But having said that, I work in a tertiary hospital, like 1,000 bed. We converted one separate hospital for ICU, but the problem there was not the hospital or beds or other issues, because there are so many supports coming from international donors. Like initially we had shortage of like the PPEs or things, but after government took a lot of efforts to bring that. What we felt was regarding ICU, human resources were the main important thing, and we had not prepared our manpower well. The nurses, allied healthcare workers, doctors, we didn't have adequate healthcare workers to work during the massive pandemic. So I would first of all recommend like maybe having a trained manpower to some extent who are able to work in any situation. Like I think we should prepare some of those kind of critical trained manpower to work in those sort of pandemics.
Okay. So in Nepal, Subhash, you really felt that the manpower, the trained manpower, was the limiting factor to face this epidemic. I'll come to Dr. Srinivas, who's my good friend. So Srini, India is in a very unique situation during pandemic, because Europe got really hit very badly, and we were seeing the case fatalities sitting around 4 to 5 at some point of time in Europe, and US also then followed, and US also had a really bad outcomes at that point of time, and India in that way was little sort of had a time that it hit us after it hit Europe and US. And India is a very diverse country, very heterogeneous, and our healthcare systems are from public to a private to ultra modern private or quaternary. So we have healthcare systems which are distinctly different in different geographical location as well. We have cities, we have towns, we have second tier and third tier cities. So we had our own unique challenges, but if we look at the data today with regards to the type of deaths, although there is a debate that we did not report everything, but our CFRs are way low compared to some of the Western world. So Srini, what are your observations as what are the lessons that we have learned? Did we really do well in this pandemic, or did we underreport? So because there is huge criticism that we underreported. So your thoughts on that, Srini?
Thank you, Pradeep. So I think given the magnitude of the pandemic and the population we have, I think we did extremely well in limiting the mortality with this disease, with this condition, with this pandemic, beyond what we ourselves expected. I think the credit for this should go to the pre-existent healthcare worker system, which this country has nurtured over the last few decades. If you know, if you understand how our primary healthcare workers, our multipurpose health workers and our Anganwadi workers work, they are actually located in the towns and districts, and they do a door-to-door search for pregnant women to give them hematinics, to give them advice about antenatal vaccination and growth monitoring. I think that system came into the picture twice. Once when we were trying to screen the population incidence of COVID during the second wave, and second, it helped us to reach with the vaccination process. Because we were able to reach door to door with the vaccination process and get it executed with good efficiency. I think the reason for that is India is already experienced in doing door to door vaccination. If you know the pulse polio campaign which we run, where medical students, nursing students, paramedics, they go with the vaccine to the doorstep of where the children are and vaccinate them against polio. So we have been able to achieve that. So I think that infrastructure stood India in good stead when we fought against the pandemic.
So just reflecting on what Dr. Subhash said, you felt that we were in a little better situation with regards to our manpower allocation. But did we do well in our resource allocation? Because that's where I think we may have faltered.
Yeah, I think we did falter because as a country, we haven't invested in having our oxygen delivery and oxygen production systems ready or in enough quantities to reach. Of course, the COVID was not a pandemic of the magnitude nobody could imagine. But by the time we realized that we need to set up oxygen plants in the districts and make it available to the primary health centers and district hospitals, the first wave had passed by. So I think we faltered there. But what is also something in favor of in our country is that a lot of indigenous manufacturers were able to get basic ventilators ready in a short span of time. Between the first and second waves, if you recollect, Pradeep, a lot of good quality Indian ventilators came into the market. Yes, they may not match the intensive care requirements, but what was required to ventilate the COVID lungs, I think we did get it in place. That is an added advantage, but we were not ready from a pre-existent infrastructure-wise to match this requirement.
From ICU, since we are all intensivists, from ICU perspective, there is a huge wedge or a disparity between the public and private systems. Do you think India coped well in the public system from ICU perspective in saving lives?
I think so, but they were overwhelmed. They were overwhelmed in the sense they did not have the infrastructure
and even a trained
manpower. They did not have blood gas machines to guide us what to do. On the other hand, the corporates became too expensive for people who required high-end intensive care. I think there were plus and minuses on both sides. The corporate had the infrastructure and they had the ability to cope with this, but people couldn't afford. Good number of patients could afford.
So considering the leadership, this is one last question to you. Considering the leadership position that you have, do you believe as a society like this, we have a moral responsibility to train manpower in the public system in intensive care? Would that be a lesson that we have learned that we should equip them with, as Subhash said?
I think as an intensive care society, it is our moral responsibility to teach early warning signs to the grassroots people. You are talking about paramedical staff. You are talking about technical staff. Not only a viral pneumonia, probably something like a sepsis, for example. You can easily pick up the subtle warning signs. If you can train these door-to-door healthcare workers whom we have in abundance in this country, I think we can do a lot. And I think as ISCCM and other professional bodies, it's our moral responsibility to execute it.
Yeah, thank you, Srinivas.
Okay. So we got an idea about Asia and a bit about Europe. So we'll move on to South America. So Professor Machado, what was your experience? What do you think would help us in the future?
Well, Brazil, I think, had one of the worst experience in the whole world. We had one of the highest fatality rates, and it was on March last year we were losing 3,000 lives a day. And one of the most important lessons, I think, it's that we need to separate politics from healthcare. And this was one of the worst things that we had in Brazil. It was the mix between politics and healthcare. But one of the things that I think we should bear in our minds is that we will probably forget this on the next upcoming years, because we have no idea when we're going to be reached again by another virus. It can take 10 years, 20 years. The last one was influenza more than 10 years ago. And it reached us and we forgot. We forgot how to react. And so how can we remember this 20 years from now? And I think it is keep speaking about it every meeting. And be prepared, for me, means have our protocols ready and keep the memory. And another thing that we need to be prepared is to improve research capacity in our settings, in the low and middle income countries, because we're going to be reached again badly, much more than the high income countries. And we need to be prepared to answer quickly which drug is going to work, which is the treatment that will help us. And for this, we need to enhance our country networks and maybe work in a network of networks for the future, so we can be ready. For instance, in Brazil, we are able in 3 months to run a trial and get it published in New England, because we had already BreakNet, we have the coalition trial, we had people that were working in research together. So I think that in the next years, the main lesson is we need to work together to be ready.
Are we in the process of getting that network set up now? Do you think we have done it enough, the networking between
I agree with all my colleagues. When COVID-19 pandemic, it came like a tsunami when we are relaxing. Now we can say we learned a lot from these lessons, a hard situation, difficult scenarios what we have. So these things will help us, because in that time you have to provide clinical management to your patients, research work, as Dr. Flavia said, and you have to work to release very quickly for a vaccine and to work on for the treatment as well. Our experiences and our challenges in Middle East, particularly in UAE and Emirates of Dubai, they created immediately what they call COVID-19 Pandemic Task Force. The government and the healthcare authority at the time created what we call controlling central operating room or command center. This command center was a network with the all system to all hospital healthcare facility, whether private or governmental, how many beds in the hospital and how many beds in the ICU department. And they created for those who require only isolation. They took the hotel because at the time there is lockdown, curfew, no flights. They took the hotel because no one accommodate the hotel for those their symptoms allowed to be only isolated, and those requiring treatment and equipment will be hospitalized. How many beds? So from the central room, they can say Prime Hospital, they have 2 ICU beds and still 5 dedicated isolated rooms. They can see the map in the central operating with the ambulance services. So once any patient start to have a symptom, we have PCR to be tested very quickly if suspected case, and according to the algorithm and regulation, WHO is working to release as soon as possible any guideline helping us starting to the treatment, supportive treatment, and some of the medicines start to talk about it. We take from WHO, and we are working on unified protocol and regulation, which was being updated monthly base if it is the same or something new come from the research world. It was really very dynamic process. We lost lives definitely, complicated cases definitely, but we saved life as well. The medical team was overwhelmed, but always dedicated to save lives. Yani, the matter was horrible at the time, and day by day, month by month, start to have more information about this new enemy, more experience, more challenges, and the medical team now is more and more aware what is going on, until I think we reach to the peak. After that, this peak start to come down, and there is more confidence now. We can one day compare this new enemy by these things.
Dr. Adel, I had actually the last question for you. The reason is because I think Middle East would have been most prepared, I would have thought, because you had an experience already with the Middle Eastern respiratory syndrome. So I was about to ask whether you felt that you were better prepared than any of us here, because you already had faced the most recent MERS pandemic in
yes, I agree.
So
with
did you think
yes,
the preparation was adequate to face this pandemic in your Middle East?
I agree with you, Dr. Pradeep, because it come in the MERS from Saudi Arabia at the time, Gulf region, and we are working on maybe Middle East, because the last endemic, it comes with MERS, then we came after that, maybe 7 or 8 years with 2019 with COVID. We have the system, with the healthcare system well established there, with the equipment from the beginning, for just in case for any bad scenario, mass casualty or something bad, it will come like endemic or pandemic. And we were ready with the equipment and machines, and even the expensive medicine, the government helped us a lot to be availed and to be provided on time by even sending the medicine very quickly to all hospital to be ready for any case requiring these lines of treatment.
I think that's a very, very strong, important message, very strong signal coming from your end, because you felt more equipped, more prepared, and you had no resource crunch. I think that's a very strong message for all of us, that we that our countries also should invest in good preparation of allocation of resources and having backup of the resources. So coming to the second step as an intensive, because this whole discussion will be focusing a bit on intensive care. From ICU perspective, Professor Quirino, we came at the forefront, really, I mean, in an unanticipated way, and we were involved, in fact, guiding our governments about triaging, and ICUs were the place which were being overwhelmed, and our whole pressure was on ICU and healthcare establishments because there was crowding of people who were panicking, and not necessarily they had to come to hospitals. So that is where ICU took the leadership role, and at least in my part of India, we said, please check your saturations. Only if saturations come to less than this, come to hospital. And even in hospital, triaging system was put in place, and this triaging SOP was created by intensivists, which means to say intensivists really came in the forefront, trying to take things into control, and we felt that we were possibly better equipped in trying to triage and see which are the ones who need to come to ICU. That is one aspect. That is with regards to triaging, and the second thing is even to try to do certain, equip our laboratory to do certain cursory tests in the emergency to determine as to who comes to ICU and who do not come to ICU at community level and at the ER level. So do you believe that ICU should be taking more such frontline efforts with regards to equipping the triage SOPs and with regard to equipping certain lab infrastructures which helps us to better gear in triaging these patients, because the whole problem in the world was the hospitals were being overwhelmed. So do you believe that from intensive care we can generate certain SOPs to mitigate this overwhelming sort of a situation that arose? Professor Quirino.
Okay, for me ICU is the core of the care in the hospital. Of course, during pandemic is strategic, okay? The problem is, the right question is what lesson our government learned from this pandemic? None, because this is not the first pandemic. Do you remember Ebola pandemic, Zika pandemic? We have a pandemic NH1 every year. And we are starting always with the same speech, because what the government prefer to do is protect their economy. They don't protect the citizen. This is the difference, and it's worldwide, from South America, from Africa, from everywhere. This is my convincement around the world, because I am a consultant of many governments, also of China. Okay, so the ICU beds are very important, but what happens in all around the world? You cannot prepare intensivist just like this, like a miracle. You need years and years of training, and this is just how to plan, not to follow behind the pandemic. We, in all the world, we have a care, we have needs of anesthesiologists and intensivists. We don't have, because our specialized schools are prepared not for this pandemic, but for normal activity. This shows very clear the lack of preparedness of our important authority. And for this, I ask to each government, and is their duty, is in their by law, to prepare a plan for the next pandemic, because for sure we will have another one. And we started with the same speech, how we can prepare, how we can give equity. It's not important, private and public, because we have also in Europe these differences. But the private institution, when you have a pandemic, are obliged to do the same things of a public. In this way, you show the equity to your citizens. But if you don't planning before this principle, we fail again.
Thank you, Karina, for it.
I am not optimistic, you understand. But for this, I ask to the European Commission to print a coin of €2 of legal value with doctor and nurses. Thank you for your sacrifice, because you remember all over the world we have a lot of dead people, for nurses, for doctors that have nothing, and they work in emergency without gloves, without mask, without helmet, without and so I would like, and I pretend, this coin, because no one can neglect our sacrifice.
Thank you very much, Bruno, for very provocative thoughts on that.
It's very human, yes, thank you. And yes, again to Dr. Srinivas and Dr. Pash, you also think that what about the triage and the treatment priorities and the ICU necessity in our part of the world? Did we, like you think, had the same problems that Europe and South America
there was
had?
a distinct difference in the patterns of our demand for ICU between the first wave and the second wave. A lot of panic in the first wave, possibly because of a lack of understanding of what the disease was. And there was a lot of apprehension amongst the other healthcare workers in chipping in with their support for non-ICU related care. So a good number of patients actually stressed the ICU during the first wave. But the lessons we learned from the first wave and the realization of what can happen and what cannot happen with the disease and what level of precautions are enough for these patients probably helped us in getting some of the patients to stay at home, as Pradeep said. And I think there we must concede that the availability of technology, like a simple video conferencing, which is now all over the country, even the remotest parts of this country have access to video conferencing and video calls. So that actually helped us to monitor patients, keep them at home and manage them, so that the stress on the emergency rooms and therefore on the ICU did come down. Although the volumes of patients in the second wave were much higher than they were in the first wave, the availability of manpower who were more informed and were less apprehensive of taking care of these patients probably was a little better in the second wave.
Yeah, and Srini, the one question I wanted, specific question for all the team members here, is we came at the forefront of every aspect of care, including the treatment, right? And we were involved in the protocol creation for my state government. I'm sure you were involved in your government. And we were the ones who were telling which are the patients who need to be given steroids.
Yes.
But so which meant we were in the policy making positions telling government that this is a very specific subgroup who has to get steroid. But this was indiscriminately used later on.
Yes.
So do you believe that ICU sort of a role was pivotal to helping patients? At the same time, this was overlooked by other treating personnel in indiscriminately using the steroids for someone who did not use at the community level, which possibly caused harm also. So what are your thoughts, quick thoughts from you and Subhash, and then we'll move to Flavia after that.
Yeah, I think the governments did take our opinion. We mostly, you, myself, Dr. Rahul Pandit, Dr. Dhruv Chaudhary, for example, we were all part of the core group of advisors. But as you said, the government did regulate the use of remdesivir. They did regulate the use of antifungals for mucor. But I think the regulation which was needed at the pharmacy level for dispensing of steroids was not very effective. And patients were able to get steroids across the counter because of the nature of the pandemic and the panic that had triggered. And as you said, that really had a lot of adverse consequences.
Quick thoughts
Yeah,
from
it's
Subhash?
the same with us also. Like we were involved in drafting guideline for from our medical council. In fact, our medical council drafted the guidelines, and our society was a part of it. And exactly, there were some policies regarding remdesivir from the government, and as it was not that easily available, and later about other drugs, but steroid was available everywhere, and everyone was getting it, and probably that is one of the reasons of its bad effects, side effects we saw later. Totally agree.
I think it's very clear from all the panelists here that intensivists really took on a multimodal role. As Professor Quirino said, our role initially before this pandemic was limited to caring for very, very sick and unwell patients in ICU. But when pandemic came, we became the policy advisors for a lot of people as to how effectively it needs to be managed. That being the case, so I want to put this question to Flavia, that you have a code blue team in ICU, and then you have a code gray team or code yellow team, code pink teams. Should we have a code pandemic with an intensivist as a lead for a hospital, for a state, or for a country, a team, a think tank team led by an able intensivist? I using the word intensivist because during the first pandemic, Srinivas would agree with me, many doctors were not coming to hospital. It was an intensivist, ER physicians, chest physicians, surgeons wouldn't come. No, they felt this is not our problem. It is a problem where patients are dying. And honestly, each one of us sitting here would agree, we were the first one who took the wrath and we fought it out and emerged successful. So should there be a code pandemic set up?
Yeah, I think so. I think we are part of this core team, but we are not the only ones. For instance, in our hospital, in the triage, before the first patient arrived at the hospital, we have already had a ethical protocol established for triage. And who made this triage protocol? We, the emergency physicians, the palliativists, the clinicians, everyone. So everyone contributed, and it was signed by the hospital directors. So we already had this, and we are part of this team. So I think that you are completely right. Who were in the hospital? We, the emergencists, and the infectious disease doctors only. So yes, we are the core team to have to take care of for the next pandemic. But one thing I think it's a key role for us, intensivists, the multidisciplinary team of the intensive care, is to work on prevention. Because we need to remember that most of our patients didn't die because of COVID. They die because of nosocomial infection. They die because of our strain, the stress in the ICU. So to be prepared for this and the whole that we have, I think it's to work on the prevention side. And regarding the protocols for the country, I also agree that intensivists are part of this, but infectious disease doctors as well. And again, politics mixed everything. In our case, for instance, our president, with that early treatment hydroxychloroquine thing, the whole bunch of experts had said no role for hydroxychloroquine, and they just ruled this completely out. So again, the mix between politics and health.
Yeah. So yeah, I would like to ask a question, like for anybody actually, it's open to. And so what we saw, I've come from Sri Lanka, is that data came from so many countries, like mostly developed countries. But whereas when it comes to the developing countries, the data was not published and we didn't know actually what was happening. So, and also the outcome was clearly different between the countries, the regions. So to get a uniform outcome, because we are talking about humans as a whole, so everybody should survive this. Is there any way that we can make the data collection uniform and then the research uniform so that everyone get an equal chance to fight this battle?
Yes. I agree with the whole colleagues. So if we are talking about patients like COVID, when presenting, we have, according to the severity of symptom, we are talking about those kind of patients came to the hospital severely distressed, hypoxic, and sometimes shock state. If we consider the main, like before COVID-19 itself, how the intensivist treating such kind of patient, there is a standard protocol for those patients who are putting them on ventilator assistant devices and oxygen therapy, and if they are in shock state, what we are doing with them. If till today, when we are talking about pandemic, it is finished or not, there is no specific treatment for COVID-19. If you are talking about hydroxychloroquine before, when they start to talk about it, steroid, the rule is steroid, it is really or not. If you are talking antiviral, remdesivir, it is a specific, not a specific treatment as of now. Anticoagulant, whether intermediate dose between prophylactic or therapeutic, you cannot give a final conclusion, this is a specific treatment or what. All of them will come back to the standard care of patient who presented to ICUs with respiratory failure or other organ failure. Those patients really, once you immediately take the immediate action, like our protocols even before COVID, they show the favorable outcome, those patients. Despite we started steroid with them or not, despite we use antiviral treatment with them or not. As Dr. Flavia said, the antibiotic at the time, if there is mixed or superimposed or secondary infection, if you didn't, they might die from the bacterial infection, not the viral COVID itself. So back again to our standard, if you are talking about one language we are intensivists are using, again, the main standard protocol for managing such kind of patients is very important. Research work is very important, but till today, no conclusive finding that there is these lines of treatment or a specific treatment for COVID-19 what we have in our hand. We cannot say that. So back again to talk one language as all together, back to the standard management of such kind of patients.
Thank you, Adel. I think we have 3 minutes, so we are coming to the end of the session. So Srini, your quick comments, because I think our government seriously has forgotten the pandemic already. I don't know, we'll take inputs from other countries, and I don't think they're least bothered whether second pandemic strikes or third pandemic, because I don't know, because the preparation doesn't seem to be at a unit level, so I don't think it is at a bigger level. So do you believe at the leadership position that you are in a society that this relentless effort by a team of driven people, intensely, because we took the wrath. So the driven society or the driven people at the helm of the society keeps working relentlessly on preparedness from the governance and making very evident that there should be a code pandemic that needs to be created at a unit level, state level, country level, so that we deal with this very effectively. That is one. The second thing is we perform very poorly in research, because all the good research that emerged which saved lives in COVID were multicentric, and somehow we have always struggled with a good multicentric, although vaccines did well in India. But with regards to therapeutic options, we really did not do good research in a multicentric format. So how do you think from a societal standpoint as a leadership that we put in a relentless pursuit towards this direction?
Yeah, I think as Dr. Flavia said, we should not forget this pandemic for at least another 10 years. And the reason and the way we should not forget it is that, of course, we'll have discussions like this in an annual congress, but as a responsible society, we need to take the message of pandemic preparedness to the community. We need to go to medical schools, we need to go to nursing schools, we need to go to schools and colleges which teach paramedics and tell them that yes, another pandemic can come, and when it comes, this is the better reaction we expect all of us to do to improve outcomes, I think, as a society. And then we can collaborate with other like-minded societies like the anesthesiologists, the physicians, all other like-minded societies, and have a common program mutually. Of course, there is a surgeons program happening. The Indian society should volunteer to go there and reiterate the need for pandemic preparedness. That's the answer to the question number 1. And on the same tenor, the ISCCM, being the apex research organization for critical care in this country, has a responsibility of inculcating the culture of maintaining good records and of analyzing their data, which again I think is a part of training program, and we should take the lead in meetings like this in having data analytics and clinical research methodology orientation to all doctors, not necessarily intensivists, for all doctors. If we can do this, I think next time when something, I wish and hope it doesn't happen, but we can only wish for it. But if it does happen, we are better prepared and we make a more educated decision making available to all of us.
Thank you. Thank you, Srini.
Yes. Actually, we have come to the
quick comments from rest of the panel and we'll close it. about.
I think that the critical care society is strategic all over the world because they can help the government to fill the gap of knowledge because the intensivists like the anesthesiologists, because in many countries are the same, both, okay, are able to handle the most modern devices for help, the respirator, the ECMO, very important devices that are health-saving. And also they can suggest to the government how many doctors we need or how many ICU beds we need, okay? But I agree with my colleague, we need to standardize and more collaboration with the other specialty. For example, not only the COVID-19 patients go to ICU, but the first stage they go to pneumologist, to medicine internal, because we have a strategy with a non-invasive ventilation, and we can have a common protocol. Only if the severeness of the disease increase, we can transfer the patients in a majority level of assistance like ICU, or first level or second level. So if we have this reservoir of in the hospital of a bed, we can support the pandemic. Otherwise, if anyone go by each themselves, no, I think that we have no chance.
Thank you. Few comments from Adel.
Yes, we are, for all pandemics, you can say we are all responsible. Government, health sector, and public awareness all are sharing in the same fate at the end for the final outcome.
Abia?
I think that we shall never forget,
Yes.
never forget. And we will, if you do not do anything about this, we will forget in some decades. And we're going to be only a paragraph in a textbook of medicine. And to be prepared, the best thing is to learn how to work together all around the world, in all fields, in assistance, in research, in producing good quality of care, because the way to go is to get back to the basics and do the basics nicely.
Thank you. Dr. Subhash?
What I feel is and recommend is that I think we should have some sort of collaboration among various critical care societies, and maybe the World Federation can take some lead. In fact, other societies like the CHEST or other societies, they have a particular committee who takes care looks after disasters and pandemics. So maybe the World Federation should take a lead and make a small committee who can make plans and policies, and if a policy come from a World Federation level, it will be very easy for everyone to accept it and implement it even at the grassroots. And so I think for a country like ours, so low resource country, if something is prepared and the policy is given, then it will be very easy for us. Despite the challenges, we can implement those things and work to save more lives.
Yeah, Dr. Anushka, your thoughts, and I'll close the session.
Yeah, I think we had a good discussion and it was quite productive, especially considering that we have experts coming from all over the world, and actually coming from a low to middle income country, we have a lot to learn from people like you, and it was really effective, and thank you very much for that very fruitful discussion. Thank you.
Yeah, I think one message that came very strong and loud is that we cannot forget the pandemic. So as an intensivist, I think my take-home message is, I think, key to changing others. Here we are telling that we have to keep reminding government, we need to keep reminding our other colleagues, but I think key to changing others is to the key to changing others is to change oneself. So I believe as an intensivist, we should take the frontal role, and possibly in every forum of this nature, this has to be recalled, because out of mind, I would say it is out of preparedness. So we should not get this pandemic out of our mind, at least an intensivist mind, and be reminding ourselves so that we put this relentless process in place, that we are well equipped and better prepared for this. And one link possibly we missed in this whole discussion is the value of epidemiologists. So possibly intensivists should continuously work with the epidemiologists, keep taking the cues and see how we can prepare better SOPs for future pandemics. And I believe intensivist is there to lead, and here we are all there. We should keep reminding ourselves and putting in an effective SOP for the future pandemics. So thank you one and all for being part of this studio, and I wish you all the best.
Thank you.
Thank you.
Thank you.
Thank you.
Well done.
Good evening, everybody. We are going to discuss a very important topic, a more human ICU. Because in the recent past, the critical care has grown a lot. We are doing a lot of monitoring, invasive procedures, intervention, and we have definitely improved the outcome. But in this progress, probably a human touch has been lost. And we treat more over a patient as our physiological subject rather than a human. And that leads to a lot of distress, not only to the patient, but with the family as well. So, to discuss this, we are interviewing Dr. B.K. Rao. He is Director Clinical Services at Yashoda Hospital, Ghaziabad. We have a Dr. Oh, I'm so sorry. I'm so sorry. I'm so sorry, sir. Can we restart? Okay. Dr. R.K. Mani, he's a Director Clinical Services, Yashoda Hospital, Ghaziabad. We have a Dr. Vinay Nadkarni. He's a Professor in Anesthesiology, Critical Care and Pediatrics from United States. Dr. B.K. Rao, he's a Senior Consultant and Head of Critical Care Medicine at Sir Gangaram Hospital, New Delhi. And we have a Dr. Asit Hegde. He's a Consultant in Medicine and Critical Care, PD Hinduja National Hospital, Mumbai. I, Dr. Vivek Gupta and Dr. Kavalpreet Sodhi from Ludhiana will be interview and will ask questions how we can make our ICUs more human and we can integrate and maintain the quality of both our services as well as we can make it a more patient-friendly ICU. So to start with this session, my first question goes to Dr. R.K. Mani. Sir, there are a lot of definitions. People say it's a holistic approach. Everybody will take it as a different definition for holistic. So what do you feel, what should be a definition for humanizing the ICU?
No, I would put it simply. I think the crux of the matter is we must value the patient as a person. You know, very often we say that pancreatitis on bed number 10 or that septic shock on bed number 6. While it is useful to identify like that for discussion among ourselves, but in the background of that we must be aware of the fact that we're talking about a human being. So valuing the person, and actually the disease is in a person. It is not separate from the person. And similarly, one must value the families which are there outside the ICU waiting to hear from you. So if that is the central sort of goal, to value the people for whom you're working, the patient and the family, I think the rest of the principles of humanization can be a natural corollary to this principle.
Thank you, sir.
Next, I would like to ask Dr. B.K. Rao, sir. So, being into the administrative post, firstly, I'd like to know, why does this dehumanization of patient occurs? And as an administrator, what are the main challenges in changing the approach in an organization?
Because of the very nature of critical care, there are certain interventions, there are certain restrictions, there are certain procedures which are laid down by the team, by the ICU administrator, by the hospital administrators, which basically, though essential for the care, it kind of takes away that human touch, one. What is humanization? It is individual and it is also universal. Individual in the sense and universal in the sense that as we grow, as we become aware of what we are, we develop a sense of what makes us a human being. And we would like that to be maintained. Whether we are healthy and in our home or we are unhealthy in the hospital or we are very sick in an intensive care unit. When that thing is compromised, then we talk of dehumanization. And to the extent possible, as an administrator, as a clinician, as a hospital administrator, we must ensure that whatever is non-essential and whatever will not affect the outcome of the patient and yet make a person feel more human, that those measures must be taken.
Thank you, sir.
So my next question to Dr. Asit, sir. Sir, what intervention actually or what approach you will follow if you want to change your ICU from maintaining a humanization?
Well, we can have an entire conference on that, but just a few things. Dr. Mani's already mentioned that you should, at least while on rounds, when you're meeting with the patient, refer to him by his name. In fact, maybe tapping him on the shoulder after washing hands, of course, will help. I am very much for liberal visiting policies. I think we're going to have I mean, we should discuss that in a little more detail, but unless, you are doing a procedure or something else, but allowing relatives otherwise all the time by the bedside really would help. Improving communication, because patients with a tube, patients with neurological problems may be unable to speak. And I'm sure now we have enough apps which will probably allow better communication, for patients on a ventilator with a tracheostomy. It should be easy now. I'm sure there should be apps that will allow them, because I think one major reason for frustration is that they're unable to communicate when they have. I think we should have, I'm sure we should be able to devise devices to make them, communicate much better. I think also this whole thing that ICU should be a serious place where patients can't have fun, I think that should get out of our mind. There's no reason why they can't read newspapers, why they can't read books, why they can't watch TV, listen to music, if they are in that kind of there's absolutely, there's some small things that I think can be done to make it a more human place.
I would like to add one point here. We have a concept, or our thought is that only a conscious patient can discern whether he is subjected to dehumanization or not. I think the concept should revolve around the whole family, because when the patient is unconscious, the family is watching, and the concept of humanization is in their mind also, whether their patient is being treated like a human being. So it should extend, and the question is not only the patient, is the whole family.
Rightly said. Dr. Nadkarni, may I ask you, how is the situation different in US? How the practices differ, and how much weightage or focus is given to this aspect of humanization in ICUs?
I think in the United States, there are more similarities than there are differences in the dehumanization and rehumanization of the patient. Much more attention is now being focused on the environment, and as has been stated, the loss of control that every patient and family feels when they are in their environment. The reemergence of family-centered rounds, the inclusion of the patient and the family during rounds in the decisions, and a genuine treatment of the patients and families as if you're in their living room addressing them rather than they are in your hospital is emerging as an important aspect. The control issue is being amplified by allowing more control of the environment, natural lighting, the ability to control the mood of the room, whether they're sad or happy, communicative or not, and the privacy issues being respected. Those are things that I think are emerging. The one difference that I think is a little bit evident as I tour the Indian hospitals and the US hospitals is the slight difference in the paternalism. I think the US is starting to be less paternalistic in decision-making processes and the involvement of the patient and the families.
Thank you, sir. So my next question goes to Mani sir. Sir, on one end, we really feel that we are highly skilled for doing procedures, monitoring, making good interpretation in our ICUs, and that really makes a difference in the outcome. But on the other hand, this is one extreme of the intensive care management. But on the other hand, what happens? Once the patient has deteriorated, and we know that it's a irreversible situation, there's the least chance. So as an intensivist, I always feel there is a vacuum. What next? What to be done? So sir, what is your opinion for this end?
I think an important intervention in the ICU, apart from all the technological interventions, is the intervention of communication. And this should not be delayed. It should be within 24 to 48 hours, a multidisciplinary family conference or meeting wherein we are able to connect with the family and we are able to build a trust, and then we are able to include them in what the sort of standard intervention now in the ICU. when actually the trajectory changes, right, as you said, deterioration takes place, we could build on that trust and then open up the conversation as to the options now available to us. If there are no curative options now left, then also to suggest the option of proceeding on to comfort care or options more focused on patient symptom control and the humanistic concerns, right? The family could go into an emotional turmoil or stress. To be able to recognize that and to be supportive is also an important quality measure, I think, in the ICU. So both in the structure of the family meeting and the content of the family meeting, we can focus, shift our gaze to that, and that I suppose may prevent the loss of trust, or in our milieu, even litigation or violence, in our midst. I think it will go a long way in promoting the understanding between the two sides.
So definitely, sir, it means the intensivist should be trained for when it comes to a irreversibility of the disease. He must be trained for the comfort care, talking about a comfort care as well, not only of the interventions or intensive care management. Thank you, sir.
So now the H factor, what we term as humanization, this has rather become now a fashionable word in the ICUs, being incorporated into the components of the critical care itself, like A, B, C, D, E, F bundle we had. Now we have added this H to this. So as an administrator, again, Dr. Rao sir, like what are the structural or the process changes you would like to bring into the ICUs such that we have more of this H factor in our ICUs?
One big thing is training and awareness in the staff, because it is the staff who handles the patient. Second thing is the structural changes that you can bring in. Some of them have been highlighted by Dr. Ashit. The environment, the natural light, the connect to the day and evening and night, those kind of things. But I think one equally important is the family counseling room. And also patients who the family who loses a patient, they want to sit and grieve somewhere, so there has to be a room like that. And then the services where people from outside counselors can come in and kind of counsel them and share in their grief and help them out in whatever way possible. So all in all, what I say is that an individual should decide what he would expect. Should he be a patient or should he be a visitor to a loved one in an intensive care? If you can define that for your own self, you will be able to define it for any other patient.
Perfect, sir.
So my next question from Asis sir. So we are talking about a patient, relative, everything. But what about our own healthcare professionals? If a patient, they have the emotional bonding with the patient, so definitely if something goes wrong with the patient, they are going to get emotional distress. So do you think that this dehumanization in ICU helps them for some emotional distancing, and that helps to cope up with the situation?
No, I think that's not a really valid argument, because we're just asking you to treat them like anybody else. The trouble is, on a day-to-day basis outside of the ICU, we are supposed to treat other people well. I mean, no matter what they are, you're supposed to treat them like human beings. Unfortunately, it doesn't mean that everybody I interact with in the street and treat him nicely, treat him courteously, treat him like a proper human being. Doesn't mean I'm in love with him or I'm emotionally bound to him. It is just that I treat him like a human being with the respect that he deserves. That's all that is expected from me and my patient. I don't have to be emotionally bound to him. Otherwise, in medicine, we can't function. If we are going to be emotionally attached to every patient we treat. That, of course, I think is automatic. The moment you become a physician, you get that disconnect is, I think, inborn. So emotional disconnection and treating somebody just, with dignity is, I don't think they're mutually exclusive. So I think there shouldn't be a problem at all.
In certain patients who are long-term into intensive care, because we don't have long-term intensive cares in India, so they usually end up being with you for a longer time. And then there could be a bonding between you and the patient, you and the family. So there is some amount of, let's say, feeling of loss for us also. But it's not at an emotional level, it is more at a professional level.
Thank you, sir.
I would like to add that, what I agree with what my colleagues have said. See, empathy doesn't mean you're at risk for burnout. I think that's a mistake. we as caregivers have an essential quality of providing empathy, and it makes you feel better, not worse, and gives you better outcome, better relationships. When you have better relationships, I think the risk of burnout is far less. If you perhaps you're not expressing yourself as a caregiver, then the risk of burnout is higher, in my opinion.
Right.
Thank you, sir. Dr. Nadkarni, we say the ICUs are the most tech-savvy places in the hospital as such. And all of us are advocating so many interventions, the monitorings, especially in the CPRs. So how these technologies can affect the humanization in ICUs?
Well, I think it's a challenge. But just as the technology can be used to dehumanize and make individuals feel a lack of privacy, a lack of control, similarly, these tools can be used to humanize. If we think about last week, I was on service in my ICU, and during this week here at the Congress, I've been able to stay in touch using WhatsApp with the families of the children that I was caring for. I can use the VPN to look in on the EPIC, on our electronic medical record, and keep up to date on the notes that are coming in and discuss this with the family. In fact, I can FaceTime, and as the technology improves with facial recognition software, being able to determine if a patient is distressed, is anxious, is in pain, etc., we can start to address some of those things that give them back control and respond to their mood. In some of our hospitals now, we're injecting the aromas that they determine they want to smell in their room. The light scheme in the room can change based on their control. So we can start to humanize using the same technology that we have unfortunately started to dehumanize with. It's all, I think, in the strategic approach and not so much buried in the technology itself.
I have another point. You know, what we are discussing is a dichotomous, that either you are humanizing it or you are dehumanizing it. I think lot lies in between. So it's not as clear cut that if I don't do this, that means I'm doing the other thing. So we have to be aware of this, that, you know, between humanization and patient, you know, the priorities shift.
So we need to have a middle path.
Not middle pathway, but yes, we can't say that, you know, if I'm saying no, that means I'm not saying yes. It's not like that in the clinical care.
Right, sir.
Next question to Assis sir. Sir, this is one of the most important component that we allow relative to meet a patient in ICU. So this is one of the major factor which can help us to humanize our ICU. So what do you think that in Indian scenario, what could be the policy, because a lot of infection rate and people are not so literate knowing everything. So what do you think, what should be our policy? Is it feasible in Indian scenario?
Well, I have virtually opened a policy in my ICU. It's perfectly feasible. So infections are not carried by relatives. Clearly, it's carried by the hands of the health workers. A relative is only meeting one patient and going back. So it's unlikely, unless you know, he's got some transmissible illness, that he's going to carry infection to relatives. So I think that's just a myth. Even footwear and all that. So I personally think, like you said, like somebody has said, the expert on the patient is the relative, and if you keep him out of the care, you know, you're keeping the expert out of the care of the patient. Sure. So I think it's very, very doable. I really think I have realized in our country, we always thought our country is very, you know, disorganized. But now think of look at the behavior of people on the planes. You know, look at what it was 5 years ago, and now nobody jumps up out of the seats. So you just need to enforce a few rules. I think people are. I think we are underestimating the, you know, our people. I think we really think that they're capable of behaving as well as anybody else. I don't think we should use that as an excuse that they will misbehave and they will kill as an not. That's, I think. I really realize that people are, you know, they don't want them to interfere. That's why we are looking at what is good for us, not what is good for the patient.
Probably that restrictive approach, we should rethink that. That probably harming us more. Because lot of issues when patients attendants are seeing that what we are doing with the patient, probably they will be more comfortable with us rather than just having suspicious that what we are doing inside they are not aware. Thank you, sir.
Vivek, one point here.
Yes, sir.
When we say open policy, we are basically talking in the context of the Western world. In India, our families are very, very large. We have huge number of friends and relatives who would like to visit. So somewhere you have to identify, or the patients have to kind of, give authority to, let's say, these 4 people, these 5 people.
Sure.
Otherwise, every day it's a different person
so the
coming in.
The patient preference. Some people may want 20 relatives, somebody may want just 1. So that's
so every time somebody walks in who's never seen this patient before, he wants a complete rundown on the patient. So it occupies the workforce. So that has to be identified, and then it has to be an open policy.
Rightly
Thank
said,
you, sir.
sir. So human nature, I think that is the most important component of humanization, and working with so many people in the ICU. Mani sir, do you think we need to have some professional skills or a more structured course such that we implement the humanization into our ICUs?
I do think so, because I think being always trained and oriented to the curative or resuscitative or rescue mode, we are unmindful or not sufficiently mindful of the symptom complexes that accompany this. There's not just physical, it is psychological, emotional, then of course the depersonalization, the loneliness, the dehumanization, in a nutshell, you feel you're not in control, you feel you're not your own person anymore. So that is for the more conscious patient, but even for the less conscious patient, delirium is one symptom, and many times we respond very cruelly with just restraints. I think there is a whole lot of things we must train ourselves in a preventive sort of environment for the emergence of delirium, and we must not forget that the survivorship also gets complicated if we don't pay enough attention to the symptoms and the psychological aspects, because long afterwards in the post-intensive care syndrome, people have PTSD, post-traumatic stress disorder, or they have cognitive impairments, or they have other anxiety, depression disorders. So what I mean is paying attention to the symptom complexes, paying attention to the patient as a person, a touch of sitting by the patient, listening also to what the concerns are, similarly to the family, will make us truly patient and family centric. I think it's our responsibility, one of the essential competencies. They are not the add-ons, they are essential competencies to my mind, and that has to be integrated in our training and development.
Thank you, sir. So a last question from all of you, one by one, sir. This all of us have faced, I'm sure all of us have faced, that in our ICU, because of some mistake, some mishap happens, we lose some patient or some young child. I remember my resident days, sir, a young 4-year-old child was operated for cardiac surgical procedure, and he was smiling playing with us in the morning, and in the evening he died, could not come out of bypass. So still I remember that incident. So all of us have some or the other incidents. So how you handle the situation if something happens, young child has died, or some mishap happened and staff feels I'm responsible for this. So how you handle? Natkani sir, starting from you.
Well, I think it's it's much the same, whether it's in a professional situation or in a personal situation. So I think it's peer support as a key component, professional support, behavioral health, and the ability to identify the ability to pop off or to access professional help if needed. And then a time and space. So making sure that there is the opportunity to express the emotion and not to interrogate the incident, and to separate those processes so that it does not feel like an interrogation. Those are a few of the key principles, but I think the peer support, and truthfully, when things like this happen, everybody around comes up with an incident that happened to them as well that they feel responsible for. So the feeling of being alone, the feeling of being responsible weighs very heavy, but clearly is distributed amongst the peers.
Sir.
I don't think I could express it any more eloquently. He has covered most of the things. I think, like you said, you don't blame the individual, you blame the system, you try and correct what's wrong with the system. It's almost never an individual fault of, I mean, he's just the last, it's basically a fault in the system. So you, like you said, and I obviously, like you said, you give them time to express their grief. I think just their expression, give them time to express the grief, and I think no pointing fingers, honestly, is the key. I mean, that is the.
You know, I do feel that the caregivers have to be trained in certain emotional risks that they face. It's so-called resilience training, because it's very essential to the intensivist, because he or she is witness to such tragedies more frequently than the rest. And sometimes what you do and what results is so proximate that even if you're not directly responsible, you feel guilty about it. So to be able to be objective in any situation, whether it's success or defeat, is a sort of training. Right? We don't get overly elated when we do succeed, and when there is a defeat, we don't take it. When there is not defeat, when there is a mishap, you don't take it as a defeat, right? As an essential part of your practice. In fact, I don't think if you have made no mistake, you've acquired any quality experience either. So I mean, as Dr. Nadkarni said, attention to your colleague and to signs of concern, right, about the mental state or emotional state of your colleague is very important. So when we are compassionate towards our patients, we should not forget to be compassionate to the caregiver amongst and within us. I think it is the whole lot of culture that we develop and team spirit that we develop. And of course, all the work that you do for the patient is done as a part of a team, not just as an individual.
Rao sir.
I think very nicely put by the other speakers on the dais. But just one thing I want to add. Fortunately, in the intensive care, in most of the places, we work as a team, as not as individual. And those who are, at the beginning of their career, and those who have put in years of service in the intensive care, they are affected differently. So the people who are senior, they should spot. Whenever it happens with a junior colleague, they should be able to spot that that something is amiss, and that is where they should pitch in. It should not be for the junior to ask for help.
Yes.
It should be spotted, and then corrective action should be taken, whether that is support or counseling or whatever space. And if need be, you can give him time off also. But all in all, I think the whole structure should keep an eye open for such a thing if there is a sudden loss or expression of grief.
Very well said, sir.
Thank you, sir. So to end this wonderful discussion, I would like to say that in the midst of correcting the organ failures, we ought not to, as a clinician, we ought not to just ignore or neglect what our patient is actually experiencing. And that is what is all humanization is about. And I would like to thank all our 4 panelists. Thank you so much, sir, for such a wonderful discussion. And my co-interviewer, Dr. Vivek Gupta, and a big thank you to all of you. Thank you.
Thank you.
Thank you. Thank you. Thank you so much.
Good evening, everybody. Welcome to this panel discussion as part of the ISCCM 2023. We are going to discuss cost effectiveness in adult intensive care units in the post-pandemic era. My name is Amit Kansal. I'm a senior intensivist working in Singapore, initially trained in India. I work in a 700-bedded hospital in Singapore, which has around 35 commissioned beds in intensive care and high dependency unit. We are a closed unit with ICU and HDU co-located. That gives some idea about how my perspective on ICU efficiency are. So we move from there. In terms of cost effectiveness, what we're going to talk about is some background of international consensus that we aim to make. We will introduce our panelists, and this will be followed by results of the Delphi study, followed by a summary. Let's begin with intensive care is expensive. 1% of National Health Service budget in United Kingdom is spent on ICU patients. ICU costs are around 13% of total hospital costs in United States. Daily cost of an ICU bed is 3 times of that hospital bed in Canada. India is no different. On top of that, a lot of payment is out of pocket in India. Unfortunately, this survey done almost 20 years back showed that 40% of patients admitted to ICU, their families end up paying either by selling an asset or by borrowing money. Intensive care is expensive. Why? There are multiple reasons behind it. The life expectancy is increasing worldwide, including India. Elderly patients have more health problems. They need more surgical procedures. The surgical procedures themselves are more complicated, more complex, and it comes at a price tag. There are newer therapies, invariably very expensive. And on top of it, there is a rising public expectation that patients should receive a trial of intensive care, howsoever expensive that is. Number of patients who are dying in hospitals, in intensive care units is ever increasing. So that's where we come to. Intensive care is expensive. The need for intensive care is rising. We will need more and more beds. And question here is, how do we make our care cost effective? Mind you, this is not cost cutting. Cost effectiveness is where the quality is maintained or even increased at a which per se will reduce the costs. So that these things are tied hand in hand. Definitely, we want to look at the costs, but not at the cost of quality. We are talking about value-based healthcare. A lot has been written in literature, a lot of work has been done, many studies over the years, as we can see here, which have tried to decipher what is cost effectiveness, what are the strategies that are deemed cost effective. This one particular comment from an author in one of the editorials summarizes it very well. At best, despite years and years of research and efforts, our understanding of ICU costs is very superficial. And on top of it, pandemic hasn't helped the situation. Before pandemic, we were always talking about just-in-time inventories, just enough stockpiling of drugs and equipment. This all has changed. Definitely today we are in an era where we are talking about just in case. Just in case another pandemic strikes. We need to have enough stockpile. We need to have enough human resources as a buffer to give quality care. That's where ISCCM leadership decided to do an international Delphi survey. So Delphi process is a process of making a expert consensus on a topic when the research is not very helpful or contradictory. So our question was, what are the cost-effective interventions in adult ICU in post-pandemic era? At this point, I will introduce my panelists. We had a session earlier with the other panelists. I request my panelists to introduce themselves and talk briefly about what makes them passionate about cost effectiveness.
My name is Vinay Nadkarni. I'm a professor of anesthesiology and critical care and pediatrics at the University of Pennsylvania Perelman School of Medicine in Philadelphia, Pennsylvania, United States of America. I am also the current president of the Society of Critical Care Medicine, and I personally work in a 540-bed children's hospital, tertiary care, that has 40% of the beds, 240 beds, of intensive care within that. And our new tower is going to add another 270 beds, all of which will be ICU capable, almost as if you'll have to be in the intensive care unit if you want to be in the hospital in the future. We are in the midst of a lot of cost cutting, but also, as you say, trying to balance the cost cutting with the quality, maintenance and improvement of the quality. And so the intense personal investment in really the relevance of this is hitting home quite personally, but also as a society of 17,000 critical care multidisciplinary members trying to create that balance. And as you mentioned, the COVID situation has brought to light the change in paradigm of stockpiling, if you will, versus just-in-time stocking, but a similar crisis in terms of staffing, particularly nursing staffing in our ICUs, and broadening our minds a little bit about the capabilities of those without high-level critical care training to deliver excellent critical care in relatively austere conditions. So these challenges have brought to light how cost effectiveness is important, linked with improved quality.
So I'm Andrew Conway Morris. I'm a clinical academic and intensivist at the University of Cambridge and Addenbrooke's Hospital in Cambridge in the UK. My hospital is a 1,000-bedded hospital with 5% ICU beds. And we, in many ways, face similar challenges in that, you know, we post the pandemic, we have difficulty recruiting nursing staff and retaining skilled ICU nursing staff. We're trying to do more and more with less and less. We have increasing patient demand, increasing patient complexity, and a limitation on resources compared to perhaps how things were maybe a decade ago. So we really want to maintain the quality of care that we provide for our patients, but are conscious that we have to do that in as cost-effective a manner as possible. And trying to juggle those competing pressures is a challenge, but I think, you know, one that's important to try to meet.
Thank you. So to add to that, this panel discussion is not about recommending anything. We are not making any recommendations. This is a thought-provoking process. We want to share with the audience what some of the interventions were discussed as part of the Delphi process. Idea is to take home this discussion, think what is working in your unit, what you think will work, can be done on top of it. So idea is to have a global perspective. Idea is to have themes of what we think, what our panelists in our Delphi survey thought would be helpful. It has to be tailored to the local needs. So with that, I start with the first poll question along with the Delphi results. So the first question that we asked our audience was, is a multidisciplinary patient care model future of or present of how intensive care should be practiced? This model can consist of a trained champion who can be an intensivist, trained ICU nurses, physiotherapists, pharmacists, speech pathologists. And mind you, this has to be tailored according to local needs, regional needs. So I'll open to my panelists at this point to seek their views.
Anyone want to take this?
Well, sure. I think it's, I think as we can see, I think there was strong consensus that the multidisciplinary patient care model is necessary, and that the implementation and maintenance of that, including the training, performance, and outcomes, needs to be monitored and supported. And how this is implemented, particularly how the ancillary services and the care models are developed, will differ based on local resources. But I think the pandemic has taught us that a virtual presence for some of the components of the multidisciplinary team may be possible. And so in this era, I think we'll establish the multidisciplinary patient care model, but how it looks when we round and when we take care of patients at the bedside may evolve over time.
Yeah, and I would add to that that one of the things we learnt during the pandemic was that in a push, it is actually remarkably possible to upscale your resources. And that came at a cost. I think it certainly came at a personal cost to many of those staff who were redeployed. And they went through, what was a difficult and challenging time. But certainly in, my hospital, the education team were able to take a group of nurses with very little or no ICU experience, and in the space of a few weeks, rapidly upskill several hundred nurses to the point where we could double our ICU capacity. Now, if we think, how could we do that under a less pressured environment, with less stress, with less of the anxieties about a lethal virus and uncertainty, and also hopefully less of the sort of pressure on care? It shows that we can utilize other resources. So I'm absolutely not saying that we shouldn't have expert, highly trained ICU nurses. No, we absolutely should. But we should also, especially at this time of staffing difficulties, be looking for other resources. Are there other professional groups? Paramedics, and in the UK we have operating department practitioners, so essentially anaesthetic technicians, for want of a better term. There's groups of professionals out there who may want to be able to get involved in intensive care. And I think what's less important than the name badge they have is that the skills they have. And we shouldn't get too hung up about, you do this because you're a speech therapist, or you do this because you're a pharmacist. It's about what skills do you have. And clearly they'll be influenced by their professional background, but being flexible about how we manage our team to local circumstances.
And may I add to that, the part of that may involve planning for the next pandemic as well, where we need to have some SOP written or otherwise, how we're going to train the next batch if that thing happens again.
Absolutely. I think we can be certain that sometime in the next probably decade, we're going to experience at least one more pandemic. Unfortunately, those who think that that's there for their lifetime, much lovely as it would be, I don't want to go through it either. But it'll come, sadly. Perhaps not as bad.
All right, we move on to the next question that was raised to our Delphi participants. How much should be the emphasis on prevention of healthcare acquired infections, even before COVID, even after pandemic? And we had a very good consensus in terms of agreement, and strong agreement, that we have to put our resources together to prevent hospital-acquired infections. I ask the panelists to comment.
So, I think to some extent this is a sort of slightly motherhood and apple pie thing. You go, well, do you want your patients to get secondary infections? No, of course not. That goes without saying almost. The question is, how preventable are these infections, how reliable is our diagnosis of them? Do we really know they're there? And if they are preventable, how much effort and money do we put into things? So if we take ventilator-associated pneumonia as an example, commonest nosocomial infection, it's definitely a problem. It's almost certainly overdiagnosed. And there are a number of techniques that are promulgated for preventing it. And the data is that you can prevent what looks like ventilator-associated pneumonia, but it doesn't seem to reduce your use of antibiotics, and it doesn't seem to alter your mortality, which is a bit counterintuitive, because surely having a secondary infection, particularly with a multi-drug resistant bug, can't be good for you. And one of the reasons for that is because of the difficulties with diagnosis. And so, most of the techniques that are there for preventing VAP are really about preventing upper airway colonization. So subglottic suction, keeping the patient sat up, sedation holds, and so forth. And really what we might be doing is preventing people getting positive cultures on an endotracheal aspirate in patients who happen to have chest X-ray infiltrates. And of course, that's probably not going to make an awful lot of difference. And those interventions come at a cost. If you're going to say we want to put subglottic suction tubes into every patient, well, you either put them all in at the beginning when they first come into ICU, or you change them at 48 hours, that's expensive, and the tubes themselves cost more. Then you have silver-coated tubes and so forth. So all of these things have a cost associated with them, and those that have the least cost, for instance, sitting the patient head up, have got the least evidence, unfortunately. So, yes, we should prevent hospital-acquired infections, and we should be looking at, we should monitor them so that we know what we're dealing with and whether the interventions we have some sort of impact. But we should also be a little bit skeptical about precisely how good our prevention efforts are going to be.
I might add that as you were talking, it brought up to me that perhaps there are some interventions that might be slightly more expensive early on that prevent the consequence. So for instance, if subglottic suction tubes were to work, I'm not saying they do, I'm just saying if they were, then the early intervention with that might prevent true VAP and a prolonged ICU hospitalization and secondary organ failure. So if that was the case, cost-effective care might be more expensive up front, but less expensive on the back end. And that's, I think, what we're trying to figure out, those evidence-based practices that really make the difference when expensively are provided early on to prevent secondary complications later.
But I think it does emphasize the need for that evidence.
Yes.
And the evidence has got to go beyond what, might be straightforward to capture, and to be honest, without wanting to be too cynical, what the device manufacturers would like you to.
For sure.
Because they want a quick and straightforward answer that they can then say, well, use my tube and it prevents VAP. We need to look at the impact on patients, because if we were using a drug, we wouldn't say, well, the drug's expensive and it, makes the oxygenation a little bit better, but we don't know what happens to outcomes. You'd say, well, show me the outcomes. And no one would license a drug without that outcome data. So I think we probably do need to be more rigorous in our assessment of medical devices, particularly when they have a sort of promulgated benefit. But I agree, there's definitely the potential there for that sort of upfront expenditure,
you might be a little bit better of that in the UK than we are in the United States with the medications.
And if I may add, on top of it, like when we talk about preventing these healthcare infections, we are talking about the whole process, which starts from hand hygiene, which starts from taking the central line out early, not intubating the patient, not putting the central line. So there's a whole spectrum, and our audience who feel they are resource limited, they have plenty to do. There are probably a lot of things that do not incur any extra costs. They need a thought, they need a planning, and all these extra things which come at a cost may have not as much, may have limited incremental benefit. So everybody can start somewhere, and we have to start somewhere. We know that healthcare related infections definitely worsen the outcomes and increase the costs. Thank you. Moving to our next question, what we asked was, where is the role of continuous training and education of all ICU staff? This question becomes even more pertinent in the post-pandemic era. In our Delphi survey, again, we got an overwhelming response to say that yes, everybody seemed to agree and strongly agree that this is something which we cannot deny our patients.
I think there's no question, ideally we would be continuously training and integrating training with care. I think in many systems right now, by budgetary need, we separate education and practice. And in order to do better practice, we have to be better trained. We don't need to just acquire the skills, we need to retain them and improve them. And we need to train not just to minimal competence, but to excellence. And this process, I think, lends itself to near continuous training at the point of care, just in time when I need it. Before this podcast, we were talking a little bit about how we get our information. We don't buy a new device and then read the instruction book any longer. We go to YouTube or some other source when we need to know what the next step is. We do that next step, we go along, and then we get what we need when we need it. And I think this process needs to replace ineffective training that we're doing now with effective near continuous or low dose, high frequency training at the point of care just in time.
I mean, again, I couldn't disagree with that, at all. I think that's absolutely spot on. And I think that is the way things are going. If I think of my practice development team in my hospital, that's a group of nurses who are, yes, they do some didactic teaching, sit down and listen, but actually they're at the bedside with the nurses going, this is how we're going to work through this today. Let's get the patient onto a filter and so forth. Yes. And, at the YouTube example, we were involved in the REST trial, which was of ECOR.
Yes.
And, I was putting the lines in, and I have to confess, each time I had to set the machine up and things like that, I watched the video as I was doing it. And, I'd say, right, I'm all scrubbed now, so can you press the play button for that bit there to remind me how to set that bit up?
That shouldn't be a confession. That should be an expectation.
And it worked,
yes, yes.
because it's something that you do infrequently. It was a new piece of kit that I hadn't used very often. And that worked really nicely. And the sort of near ubiquitous availability of smartphones, of data connections and so forth can completely revolutionize the way we do things. I think the other thing that's really important is sort of in situ simulation, because there are some things that you can't, it's very difficult to teach during an arrest, during a code. But you can teach that in a realistic setting. And it feels much, much more real than downstairs in the training room in the basement, with the grim lights and no windows. So I think, yeah, absolutely training is essential, but good quality training, I totally agree.
And to add to Andrew's point, I believe the simulation part doesn't have to be high fidelity. We don't need the most expensive of the equipment. Low fidelity simulation done properly, done in a realistic environment, probably adds enough value to the trainees, to the team that we are planning to train.
Yeah. And using the kit that you are going to use normally, so that you're not, you have the trolley that you're going to use. You have everything there. It's like when I reach for the thing I want that's normally in the top drawer, it's in the top drawer, and it's that kind of realistic training, drilling. And we think about other groups of professionals, airline pilots, the military, those working in sort of high-risk industries. They drill for things. Yeah, when's the last time your hospital ran a major incident, drill? We never do it. And yet, these things do happen. And when they happen, it's chaos because we're never prepared for them.
I mean, I just want to mention that we are talking about cost effectiveness. And as you mentioned, particularly in resource-limited settings, time is precious. We don't have a lot of extra people around to train, etc. So I believe we should also be talking about reducing the burden and decreasing the amount of ineffective training that we do. And we'll need to work with the certifying organizations who require certification of 8-hour courses, etc., if we feel that those are not effective. So there should be an evidence basis to the educational program, just like we have an evidence basis to our care and programs.
Right, thank you. So we move on to the next question, which was we ask our participants what their views are on use of electronic health records to increase accountability. So this question has two parts. One was use of electronic health records, and the second is, will that increase the accountability if we had that? So at least for the increasing accountability, there seems to be around 70% consensus, which is just on the borderline to say that they can increase accountability. It seems like a higher percentage has been neutral on this issue, and there are reasons for it, because it comes at a huge cost upfront. I'll open to our panelists.
So I work in a hospital where the chief executive was sacked because of the costs and chaos of an implementation of an electronic health record. So I can, obviously not from personal experience, but vicariously, reflect that it is not without its risks. Having gone through that process, I would not want to go back to paper records. But again, we have to say, well, has it improved the quality of care that we provide? I think it probably has. Has it made a massive difference? I think the gains have been at the edges compared to the core mission. And would it be the first thing I would do if I was coming into a hospital, that said we want to set up a cost-effective ICU? I wouldn't say EHR is the first thing to do. You want ventilators, you want beds, you want nurses, you want high-quality care being provided and that being recorded effectively. But if you are in a situation where you have an electronic health record, I think the accountability issue is interesting, because clearly it provides a much more reliable audit chain than signatures and dates and so forth in the paper. But it also raises the risk of surveillance and spyware and people feeling that they're, being watched in what they do, and that's not necessarily a positive work environment. We don't want the azomification of healthcare to come along, where people say, well, you've spent too long doing your round, or you've done that. So it's not without its risks, I would say, but has benefits, but wouldn't be my first choice as a cost-effective intervention.
I completely agree, and I want to riff a little bit off of the word you used, which was reliable source of information. I feel like it's one of the most unreliable sources, but it's the most available and disseminatable and accessible. And so if we had changed that question to having a reliable documentation and communication system, I think we would have gotten universal agreement. I think we were seeing that neutrality and some of the negativeness from the experiences implementing these, where the copy forward feature brings some real trash into the documentation that's nonsensical. But the availability to look in, to understand, to analyze sort of the massive amounts of data that's accumulated and shared is indeed helpful, and if used properly could decrease, especially with automated entry, could decrease the burden and improve the cost. But I think that's a long-term investment and not a short-term cost-cutting measure.
Absolutely. I think we can agree that if there are resource limitations, you will prioritize other aspects of your intensive care over electronic health records. Definitely, they do increase accountability better than the written notes. As Vinay rightly pointed out, the key is to have robust recording system, note-keeping. The problem with the handwriting we all know, so that's where EHRs may bring accountability, but at a huge price. So if you can, we do it, but obviously there are bigger priorities.
I mean, I wonder if you were in Singapore during the cybersecurity issues that many of the systems had, where they essentially shut down many of their communication and electronic systems, I believe, and thus had to create backup systems that, again, are maybe hidden costs that we don't anticipate when we implement these types of systems. So we should be thinking not only of the actual costs of the system, but also the somewhat hidden secondary costs that come with implementation of these types of systems.
Absolutely.
Just briefly on the positive side, though, one thing that it has enabled is better communication between different organizations and between primary and secondary care. So I'm now in a situation where when a patient comes in, I can immediately see which drugs they've been prescribed, when they were prescribed, a sort of headline list of their diagnoses and so forth, without having to leaf through endless letters and then realize that actually they'd spent most of the time at a hospital 30 miles down the road and we didn't have that information and so forth. And that has made that initial assessment of the patient and going back and making sure we're not missing, you know, long-term drugs that they should be on so much easier, and it you know, avoids those painful phone calls to the family practitioner to sort of, you know, try and get through and get some details from them and so forth.
And even the patients and families have access to their own records that they can be
yes, although again that's not necessarily
not necessarily
without risk. I think sometimes when patients in intensive care and they're not able to give consent, but they have previously consented to,
yes.
and it sometimes, you know, it's swings and roundabouts. There's definitely some advantages to it, but occasionally comes with its challenges.
Thank you. So this is something interesting, a combined ICU HDU model where as a patient is getting better, they don't need to be moved out physically. So one logic can be that this patient can be shifted from ICU to a HDU within the same same area much earlier, and that may reduce the costs. Some people may argue that this may be other way around and patients may be kept in ICU longer and the HDU costs will increase because some of the ICU resources will be utilized for them. I must confess that I work in a unit for the longest time where we have combined ICU HDU. Again, it is whether they are co-located, whether they have a common leadership and common resources, common training. When we did our Delphi survey, it seems like we have a fair percentage of our participants who did not agree or strongly disagreed with this idea, and many of them were neutral. So this is one of those interventions which has not found like very high favor, and there could be multiple reasons for it. One could be what exactly defines this model. Is it co-location? Is it common leadership? And I'll open to our panelists to put more light from their experience on that.
No, I agree with you completely, Amin.
Yeah, I mean, I've been through several hospitals that I've worked in which have been going through that transition from an ICU and a standalone HDU to where the ICU has either merged with the HDU or the management is a sort of management takeover from the intensive care side. And my experience of that in both hospitals where I've seen that happen has been that it's been beneficial. It has allowed, I think, better care for the patients in HDU because they have a clearly defined person in charge who's there and present, which is different if you're a parent team and have other commitments, be that on the wards or in theatre or in in outpatients and so forth. And it allows for that sort of smoother flow from ICU to HDU, and you're not so anxious about stepping a patient down because you know that one of your ICU colleagues will be there, your ICU nurses will be there, and it's much easier to escalate again if something goes wrong. So it gives you that sort of security blanket. There are downsides to it. Certainly, I think it's now a bit harder for us to discharge patients from the HDU to the ward, to the floor of the hospital. That's largely because of a lack of downstream beds rather than because we're hanging on to them. But there's a sort of feeling, well, it's like if you're sitting in an ICU bed reading the paper with your pajamas on, then that's a real waste of resources. But if you're sitting in an HDU bed, maybe it's not so bad, So I think sometimes there's some unintended consequences. But personally, I'm very much on the green end of that one.
Vinay, do you want to add something with regards to disaster preparedness? Is that model better? Doesn't matter?
Yeah, I think our concepts of HDU is going to change as well. The pandemic sort of illustrated that quite readily. I think the advent of low-cost wearables will also start to make us define whether we're talking about the monitoring and the technology, or are we talking about the personnel and the response and the location? Because I think the water is going to get a little muddier in the very near future about what we consider ICU. And
We're going to be talking tomorrow a little bit about ICUs without walls, that blending effect that is happening even into the home. Like HDUs may be actually home care, and are we going to go back to visiting outside the hospital, etc., right?
Yep.
So critical care is spreading its wings a little, and I think the model, some of the disagreements that we saw on the survey results may represent some local pushback organizations and really revenue models that could be influencing support or denial of such a system of combined or separate ICU, HDU.
Thank you. So we move on to the next question that we pose to our participants. Should we seek opportunities to use artificial intelligence? And obviously this question comes at a huge cost. You first have to have electronic medical records, big amount of data. But let's say today, if you had endless amount of money, and money is not an issue, what shall we do? So as part of the Delphi response, yes, we did not clarify that you had a pocket full of money, and it seems a reasonable percentage were neutral on the idea, probably for the same reason. So question, let's start with that. If we have the money, if we have the best EHRs, do you think artificial intelligence is something that will add to what we are doing, or will it replace it in near future?
It's a challenge, isn't it? Because I think at the moment where we are is that machine learning models, which we sort of loosely call artificial intelligence, are available. They can crunch large amounts of data, but they are heavily constrained by the prior assumptions made by those who've either put the data in or created the model. And so they often end up giving us the answer that we kind of already knew because they're based on our assumptions. And therefore the idea that they're pulling out something new is, I think remains to be proven. There's then another step to show that that actually improves outcomes, and that really hasn't been demonstrated at all. And I think before we spend the sort of money that we're talking about, then we need to think carefully. And the third thing is that a lot of these machine learning models are opaque. You can't actually see what's going on. So where does the liability with that lie? Does it lie with the clinician? Does it lie with the person who developed the machine learning model? Does it lie with the clinician who implements the decision that the machine learning model has told them to implement? And I mean, perhaps this is the sort of, wishful thinking and thinking that, mechanization and so forth has replaced many jobs, but they're never going to replace us. Well, perhaps there's some fear there, but I still think that, 20, 30 years from now, we're still going to have physicians with patients making decisions, because fundamentally, yes, we take scientific information and we process it, but it's fundamentally, it's a human activity, caring for a patient. And that, I think, will always require a human at the end of it, because those decisions are not simply algorithmic. So they may be able to help and support, and there may be advantages to it at the moment, but someone has to prove it. And if they're going to sell this stuff, they're going to have to prove it and resolve those other issues before we should start implementing it.
Yeah, and I agree with that, and I also think that the current strategies in terms of cost savings may be in the informatics used to de-escalate critical care rather than the escalation of critical care. Because I think we're quite rapid in escalating our supports, our expensive sort of support, our delay of extubation, our delay of some of the removal of lines and tubes and things because of our concern, our individual concern. But with the background of machine learning and artificial intelligence, we may be better able to predict the trajectories that give us confidence to be able to move forward and de-escalate faster. So I'm quite encouraged by that aspect of it, but I quite agree that we should have 100% agreements that if we scratched out the word artificial, that we should use intelligence in critical care medicine. But when we add the artificial, we get quite a sort of a bell curve of responses about whether it's cost saving or not.
That's so true. That's so true. And interestingly, I was reading an article recently. This is the work done in selection of patients who are admitted from ED to CCU for observation, who end up getting a MI. So these patients were coming with standard chest pain, ECG changes, drop leaks, and how many of them will evolve into an MI, where the retrospective model showed that they could reduce 21% admissions to CCU if they would have listened to the machine. Maybe we'll be there. So you're very correct that maybe from the escalation side, as we typically do with other things, we do what we have to do. But when it comes to de-escalating, when it comes to decision making with regards to triage and everything, these tools may be very handy. All right, so next, this is something which has a significant relevance in this post-pandemic era, where we have the landfills and the plastic waste on one side, we have the costs on the other side, and we have the infection control, patient safety, and the pandemic as one of the key parts in the equation. What do we do with use of disposable items over reusable? Do we recommend single use? Do we recommend disposables? Or we prefer reusables? And again, it seems that a significant percentage of our participants do disagree. I believe this will vary depending on which geographical area you're talking about, whether the participants had a major percentage of people from, whether it was a globally represented group in this Delphi. So that is an interesting question and an interesting response. You want to comment on that?
Well, Amit, I think the diversity of opinion here with a little bit of a heaviness on disagree there represents a common belief. But one of the things we talked about a little earlier today in the panel was also about the cost of importing items that are produced internationally and imported into India. And the fact that many of our disposables, many of our tools, much of our equipment in India is not necessarily produced in India for India and sold in India. And that really hikes up the price. So as the cost of disposable items comes down, I think you might see more agreement. When we talk about cost, though, we have to think about environmental cost, as you mentioned. And I think that is also playing into the shift towards the disagree side.
Yeah, I mean, I think the other thing, the thing is that the sort of environmental cost of a disposable, it seems really obvious because it's like you've got it, you've used it once, you've thrown it away. But we do need to look at the kind of lifetime costs, environmental costs of all the things we use. And this is going to become increasingly important as we look at the sort of carbon cycle costs and so forth. You know, for instance, we take a non-healthcare example, but an electric car. So an electric car clearly produces less tailpipe emissions, and assuming it's charged with renewable energy and so forth, it's overall less emissions. But is replacing your aging, 10-year-old petrol car with a brand new electric car overall more environmentally friendly or not? And so it's those sort of life cycle things that we need to think about. And it's the same with disposables. So what's the life cycle cost of a reusable thing? How many times are you actually going to reuse it? What's the costs of reusing it? So the sterilization and so forth. How feasible is it? So, I don't think anyone would these days argue for reuse of hypodermic needles. Yeah, we'd say they're all single use and you throw them away. But what is your cost of sending things away to be cleaned? And if you have ready access to, a sterile services facility that can clean a bronchoscope, for instance, then it might be more cost effective to use that. But if you have to send it 30 miles down the road or 200 miles down the road, then maybe your choice is between having no bronchoscopy capability at all or using disposables. So again, it needs to be integrated. I think, disposables range from syringes and needles, which I think almost everybody would agree should be disposable and single use only, through to ventilators, which shouldn't be single use only, and there's a spectrum there.
Thank you. So we move on to our next question, which I believe Vinay mentioned previously. Where is the role of these low-cost wearable devices to replace the expensive equipment for physiological monitor? And yes, this may vary on the context. We're talking about the ICU, HDU ward, high acuity environment, and it seems like we have equipoise with a lot of participants not really agreeing or not really like having a view on either side, and that shows it's not a straightforward yes or a straightforward no.
Yeah, I think there may also be some confusion about this question because if we take into account the life cycle of the existing architecture of our units and our critical care delivery now, replacing it with, even if it's low cost, it still is expensive, wearable devices may be quite expensive, and there may not be the need because there's an existing. If we're talking about new sites, opening up new areas, expansion, then low-cost wearables may, in the very near future, in my view, the reliability of them is improving, the availability is improving, and their use outside of healthcare is markedly improving. So it's quite possible that we can create, again, this ICU without walls, critical care, caring without walls, and that this will involve that. But I think the response to the question is largely colored by the interpretation of whether it's here and now, a very concrete interpretation versus sort of a futuristic interpretation of the question.
I mean, I agree entirely, and I think there's real potential for these devices for, you know, potentially continuous physiological monitoring of many patients in a hospital, far more than can be done on a 4-hourly OBS ward by the ward nurses or 12-hourly OBS, and therefore the opportunities to pick up patients as they deteriorate, or in fact to find that their heart rate variability has returned to normal, and that's a predictor of their ability to go home. So it may not just be about flagging up deteriorating patients, but also patients who are well. You know, there's a wealth of data there that will almost certainly involve machine learning to be able to process it, because there's just be so much for us to handle. And that possibility for remote monitoring, that ICU without walls, you know, we run a rapid response team which has one doctor, usually 2 nurses on it, covering 1,000 beds, and the hospital grows bigger and bigger and bigger, and the RRT stays about the same size. You know, so the ability to remotely monitor, even if it's just patients at risk, is potentially huge. And quite frankly, I'd love my patients to be on wireless monitoring without all the blinking wires everywhere. It would make life a lot easier. And the potential for home care, definitely. I mean, the reliability question is really important, because we all know that, you know, you're sitting there, the patient's SATs are reading 82, and you go, oh, the tracer's a bit rubbish, and it's because the thing's fallen off their finger. Now, if you have to send a nurse out to a ward which is half a mile away to make sure that wearable's in the right place every time you get a dodgy signal, then actually they may end up creating more work, and so forth. So there are practical implementation issues that need to be considered. But the broad principle of the idea, I agree entirely, and I think you're right. I'm sure in, you know, a few years' time they will be widespread in their use.
And let's also think about these wearables are not just our conventional monitoring. So if we think about the future where the wearing of a smart shirt will tell us about their mobility, about their sleep patterns, perhaps the heart rate variability will tell us a little bit about their anxiety profile. The video surveillance may be able to discern anxiety, stress, pain, anger, and start to trigger things that we can use and incorporate into our ABCDEFGH bundles.
Yeah, it's interesting. I have a geriatrician colleague who I've been working with recently on some infection prevention and control work, and she was telling me they'd put accelerometers on some of their patients. The amount of time their patients stay, you know, are mobile during the day is about 1 to 2% of the time. Huh. You know, and okay,
sounds like us.
Yeah, exactly. We're sitting here, but at least my watch buzzes at me, tells me I need to move. But there's a wealth of information out there that, you know, you could collect by having, I don't know, poor medical students sit there and watch how many times Mrs. Jones gets out of bed. You know, but with these sort of devices, you're right. I mean, there's so much more information that we can, and patterns that may be there that predict outcomes.
Yes.
This is so interesting. Like again, this discussion that you raised a very good point. We are not going to replace our existing monitors because any extra cost is cost. But maybe a starting point is starting from the patients who are remotely being monitored either at home or in remote areas of the hospital where there's no sunlight. So maybe those are the areas that remote monitoring is a beautiful use case. Definitely the kind of signal we get, the kind of clinical info we get from these monitors now or in future will be remarkable, much more than our standard monitoring can do with minimal hassle for the patient. So if any unit wants to start, maybe start with idea of remote/home monitoring, where that justifies the cost and that becomes effective because you can pick up the deterioration, do what you have to do, rather than in our high equity, high manpower intensive ICU environment.
But if you do also think about how this monitoring may be applied to the provider and not just to the patient. So for instance, at our hospital, everybody works shifts, and we've shortened the shifts so they don't get over fatigued. But truthfully, there's a wide variability in distractibility, fatigue, etc. On any given day for any given person. So why do we regulate the shifts by that? I think in the future we're going to be using this type of technology to allow providers to work longer if they're quite awake, not distracted and strong, and for shorter shifts if they're not.
Yep.
But it'll be based on their physiologic response and their capability and not so much on a time-based regulation.
I would just say, if, as a sort of plea from a researcher, if you are setting up, a service using remote monitoring and so forth, please, please, please do it in a structured way and evaluate what you're doing, and then publish the data so that other people can see it.
For sure.
But yeah, think about it as you implement it, and think of it. It doesn't have to be a research project, but you consider it in those terms.
Thank you. We move to our last question as part of this Delphi survey. So we had around 61 interventions, but because of the time issues, we can't cover all. We have picked up some of the interventions that were overwhelmingly selected or agreed upon, and a lot of those interventions where we could see the participants were either sitting on a neutral or a negative side. So we have intentionally picked up these items for this discussion to stimulate thinking. Now, what is the role of handheld imaging devices like ultrasound probes, which can be connected to phones, which are definitely much, much cheaper? Where do they stand in terms of cost effectiveness? Apparently, basic Sonosite or some other basic model of full-fledged ultrasound machine is around $25,000, whereas a handheld device which is connected wirelessly to phone is available for $2,000 to $3,000. So there's a 10%, there's a 90% downside in the price. So what do we think? Where do they fit in?
So I mean, I think ultrasound has grown, even in the relatively short period of time that I've been a doctor for. So in the last 20 years, where it was either the preserve of the radiologist or it was a really awful little screen that we used for trying to get a line in and so forth, to now much more widespread availability of ultrasound and it becoming integrated into routine practice. And even though the evidence that makes a difference to patient outcomes is not strong, the rapidity with which it's being picked up suggests that clinicians and physicians do find it useful. And certainly I find that it adds to my clinical examination. Now, the question is, which modality do you use? Do you go for your sort of full service big cart, or your slightly more portable thing, or the handheld device? I think that probably depends partly on what your pre-existing resources are. If you've already got the big cart, then do you need another ultrasound device? Yes, it's more portable, and it can get you out to perhaps the wards and the more remote areas and so forth. But it doesn't give you quite the image quality and the stuff you can do with. But if you're starting out and you say, well, we'd really like an ultrasound, and we've got to remember, I mean, we're intensivists, we're relatively crude people, and we sort of want yes, no answers. Yeah, it's not subtle. It's got to be pretty obvious for me to spot it on ultrasound. And so therefore I think, the really high resolution, beautiful stuff you get from the big stack is less important than I can put the thing on, yes, their RV is ballooned up, you know, in the context of this, they are likely to have had a large PE, I'll get on and thrombolyze. Or, yes, their LV is not contracting very well. The reason why they're hypotensive is not because of sepsis, but because they've had a massive MI. And so I think in those contexts, the handheld devices can be really helpful. And increasingly, again, the sort of ubiquitous nature of smartphones means that you've actually got a very capable computer with the processing power and so forth already in your pocket. Most of the time sitting there checking your emails. You know, it's massively underused. It's sort of Ferrari for going down the shops and doing your shopping. So leveraging that, the ubiquitous nature of smartphones and the availability of these portable devices has potential. But again, you've got to think, where do you put your money? And so is it the first thing I would buy for an intensive care unit if I was starting it up from scratch? Probably not. But if I was at the stage of thinking I'd really like an ultrasound machine, but I cannot afford £25,000 worth of all singing, all dancing thing, then yeah, some of these devices I think are really good and will democratize ultrasound in a way that has not happened so far.
Yeah, I think fit to purpose is really the key, and as you say, putting it in the context of existing support, but it needs to be paired with training, certification, and an ongoing program of surveillance and audit.
And just to give a perspective in terms of INR, we are talking about like probably around 1 lakh to 2 lakh rupees versus a 15 lakh unit. So there's a huge difference. And I think you rightly pointed out, it has to fit to purpose. Where are you in terms of your intensive care resources? Where do you want to fit this particular machine in? Eventually, we are going to do a lot of ultrasounds in our day-to-day clinical examination. So ultrasound is here to stay. We have to think about how we get that resource. Yeah. All right. So with that, we come to the end of some of this discussion. So again, as I said, this is part of the interventions that we have discussed during the Delphi process. The aim is not to provide any recommendation. The aim is to provide a thought-provoking discussion where these are certain points that is something which is relevant and that's something to think about when you are working or you're starting a new unit. What we have done also is that we have summarized many of these findings in under 4 buckets. So these buckets go from infrastructural elements to a coordinated team-based care delivery with a culture of continuous improvement, where we're talking about audits of competency, training, processes, and also talking about the safeguards and reliability when we talk about healthcare infections. In next couple of months, over next couple of months, we will summarize our Delphi study findings, put them together, and we will see where we can publish them. And that hopefully will be a nice thought-provoking document or maybe a brief guidance to our audience. With that, we come to the end of the talk. If you have any questions, any comments that you want to raise, please raise it at either the ISCCM, the feedback channel, or you can also feed back to me individually at my email, which we can show. It's kansal_amit@nuhs.edu.sg. Thank you so much for joining us, and thank you so much to my panelists who have joined at the end of the day. If we could have a wearable device right now, I'm sure device will tell that they're very fatigued and they should not continue with the shift. Thank you. Thank you.